Thank you for tuning in. Thank you for
I will call the meeting to order. I'll introduce myself. I am Presiding Chair Betty Ann Nettleton, representing Elmore County, along with Representative Megan Blanksma. And I will go ahead and take a roll call, starting with Boise County. Ryan, Commissioner Sturm, are you there? I'm not hearing Commissioner Sturm yet. Valley County, Commissioner Hasbrook.
This is Commissioner Hasbrook. I'm present.
Thank you, El. Ada County, Dr. Young.
Jane Young here.
Dr. Epperly.
Ted Epperly here.
Mr. Labrador.
I'm here.
Thank you. Elmore County. I don't think I hear Megan at all this time. I'm going to take this opportunity to welcome our new board member appointed by the Ada County Commissioners, Mr. Raul Labrador. And Mr. Labrador, at this time I'm going to turn the floor over to you to tell us a little bit about yourself and your interest in public health. So the floor is yours.
Thank you. I'm Raul Labrador. I'm a former member of Congress, former legislator. I'm a lawyer, and I work as a legislative assistant at the legislature with some clients, and I have always been interested in the issues that affect everyday Idahoans, and I'm excited to be here, and thank you for welcoming me.
Okay, thank you so much. Director Duke, do we have any changes to the agenda?
Madam Chair, no changes to the agenda today.
Okay, proceeding on with action items under new business. This is concerning our minutes from our January 15th, 2021 board meeting. If there are no corrections or additions, I would ask for a motion to approve those minutes, please.
Madam Chair, this is Elt. I'll make that motion.
Okay, thank you, El.
Madam Chair, this is Jane. I'll second.
Okay, thank you, Jane. Hearing no further discussion, I will call for a vote by county. Boise County, Commissioner Sturm. Don't hear right. Valley County, Commissioner Hasbrook.
Commissioner Hasbrook, aye.
Ada County, Dr. Young.
Aye.
Dr. Epperly.
Ted Epperly, aye.
Mr. Labrador.
Aye.
Elmore County. Okay. The motion does pass for approval of those minutes, and we will proceed on with Laurel McMahon's, our Support Services Division Administrator, to provide our 2021 financial report. So, Lauren, go ahead.
Thank you, Madam Chairwoman. If I may, I just want to know, this is Representative Blanksma. I just joined the call.
Oh, hi, Megan. Welcome.
Hey, thanks.
Okay, we will start with the FY 2021 revenue and expenditure report, which goes through January. And as a reminder, January is 58% of the year completed. So any of the percentages that you see above that are ahead of where we would expect to be this time of year. An overall summary is that page 1 shows our revenues are high at 74% of budget, and expenditures are on target or pretty close to it at 63% of budget. We'll go into a little more detail. The same as it has for the last several months, you'll see that both revenues and expenditures are impacted by COVID funding. And you can see this especially in the contract section under revenues, and then in variance from our original plan under personnel in the expenditures section. Looking at a little more detail in the revenue part of this chart, other revenue for support services is higher than expected due to Idaho Power rebates, some auction revenues, and auto sales. That's been the same for the last couple of months. Under community and environmental health, also seeing similar trends to what we've seen the last couple of months. Fees are higher than planned due to annual food inspection permit renewals. Our contracts, that's where you see the huge impact of our COVID funding, much higher than initially planned. Our other revenues are high due to WICHC, the Millennium Fund, and the Citizens Review Panel funds, and that's been consistent over the last couple of months as well. Under family and clinic services, our fees and contracts are pretty close to the planned amount. There's some variance. You'll see that our fees are lower than planned, and that's because of being able to offer less clinical services such as dental care. Our other revenue is high, and that includes our home visitation funding. And then our total revenue is still above target at 64%. Moving on to the expenditure section, and this is also very similar to what we've seen the last few months or last several months. Personnel and operating are low under administration because time is being charged to COVID response rather than as it had been planned at the start of the year. That's the same under support services. Personnel and operation are also lower than planned due to the COVID response. And capital is still high. You'll see that the same percentage as it has been the last couple of months. And that's because of that project payment that was carried over. And that will be adjusted in the budget revision. That will be added in for the remainder of the remodel and the parking lot upgrade. So you'll see that number shift for next month's report. Under community and environmental health, personnel and operating are still higher because of our additional staff resources, again, COVID response. And then under family and clinic services, our personnel and operating are slightly lower, and that's due to not being able to operate the same under COVID. Moving on to page 2. So both community environmental health and family and clinic services are continuing to generate fees at or above last year's comparison, with a few known exceptions. Under community environmental health, you can see that most fees have been consistent from last year to this year, with the exception of sewage disposals, which is $90,000, over $90,000 above where it was at this point last year. Under family and clinic services, you can see there's been an increase in both central care and reproductive health services. Immunizations have decreased due to the number of school-based vaccine clinics that we weren't able to offer. And then there was an impact in that child dental clinic as well, because we were unable to have the in-person dental sealant clinics in schools that we normally would. That other fees there, where you see there's nothing there, that's typically First Teeth Matter, which has been impacted since WIC clients are still being served virtually. Okay, and then moving on to page 3. So this is our cash balance statement for through the end of January. We did receive the second half of our state appropriation in January, so this page does have a big change from last year. Total month-end cash balance was over 4.6 million. Reducing it by the reserve fund designation leaves a balance of 2.3 in the undesignated, 2.3 million in the undesignated cash balance. Okay, and then on to the 4th page of this report. And this, no change in this report either. I just included this as a reminder that we still have the funding set aside to complete the carpet, paint, and furniture once we have the space in the facility to move people around and get those projects completed. I knew this will look very familiar to the reports as they've looked over the last couple of months. Okay, so that concludes the revenue and expenditure report, the budget to actual. I will stand for questions before we move on to the budget revision and the reserve fund designation.
Laurel, this is El.
Yes, El, go ahead.
In the front page under revenues, which part of the community environmental health is broken out for the replacement dollars from the CARES Act? And I don't think there's any FEMA funds, is there? It's all CARES Act. Can you break those dollars out for us in that budget?
I can do that and get it to you, yes.
I would really like to see that because that's going to affect kind of what we do next year's budget.
Okay.
Thank you. And you can email it to me if you want.
Okay. I'm just making the note on that. Okay, then we can move on to the budget revision. Okay, so starting with page 1 of the budget revision handout, this shows a comparison of the original budget and the proposed revised budget by expenditure and revenue category. And then page 2, which we'll look at next, not just yet, presents the proposed revision changes by division. So first of all, there was a lot of staff involvement preparing this revision across all of our divisions and groups. So thank you to the staff that helped with this. We looked at trends over the last couple of years, our revenues, our expenditures over the first half of this year, considered anticipated changes that we have coming up, and then we came up with our projections for the remainder of the year. Because of the COVID activity this year, it's been a little bit more difficult to anticipate how things are going to play out. So we did the best that we could with our revision, and we'll go over the details of that next. So the proposed budget revision includes an overall increase of $1,193,200. And we can see that how it's broken out. Under expenditures, our personnel has increased overall by 8.9%, which is about $783,000. And as we've talked about during our budget to actual reports, we have our increased staffing due to our COVID response efforts in community and environmental health. And then personnel costs in other divisions have decreased slightly due to staff focusing on the COVID tasks. Also of note, the CEC was included in the budget initially, but not distributed. So that balances out to an 8.9% increase. Operating is also increased substantially, also primarily in community and environmental health. Again, that's due to our COVID response. There are several new programs also in health policy and promotion that we've accounted for in the revised budget. Those include the Which See Get Healthy Idaho grant for $155,000, the Valley County Opioid Response Project, which is $300,000. That was a direct federal grant. The Partnership for Success with the Office of Drug Policy, that was $185,000 increase. So big increases across the board there. Projected cost to complete the replacement of the old furniture and install the new carpet and fresh paint, which we've been seeing on page 4 of the previous report. Those are included in the carryover for special projects, and that was approved by the board in August. That's $146,000. And then we also increased the capital outlay due to parking lot repairs and a cooling tower that we needed to replace, which was past end of life. So you see an increase there as well. For revenues, you can see there's no change in the county funding. The state general fund is decreased by the governor's 5% reversion. That's applied to our Which See and Citizens Review panel funding. Which See's funding is also reduced due to some new funding sources that are available and will be reserved for next year. Contracts increased substantially. This is where you can see that huge COVID response increase or COVID funding increase. That's over $3 million. The Valley County Opioid Response Grant from HRSA, the Which See Get Healthy Idaho, and then we have reduced funding from several contracts due to the shift in priorities back to that COVID response. Okay, for fees, those are increased by $20,700 based on our current levels. And then we also increased our environmental health fees because of those sewage disposal fees, which we just talked about being over $90,000 over where they were last year. Family and clinic service fees were reduced. Behavioral health fees had been overestimated in the original budget and have been reduced. Oral health fees have were also overestimated in the original budget and have been reduced. And COVID has prevented that program from administering services as they would have during the year, but we anticipate that returning to normal, hopefully for next year. Our other revenue is decreased by $37,900, so almost $38,000. The Millennium Fund is not going to be spent out as we had planned because of normal activities haven't been able to be accomplished due to COVID also. State home visitation funding was underestimated in the original budget due to remaining funds from the prior year. We were awarded a Pacific Source grant for COVID telehealth activities. And then just overall, between the decrease in community environmental health and the increase in family and clinic services, this funding category was decreased. The budget for interest revenue decreased by about $28,000 due to a lower balance in the investment accounts. This was estimated at last year's levels in the original budget. However, the facility remodel depleted the investment account to a lower amount. All of these expenditure and revenue changes leave us with an increase of that original figure, the 1.2 million, $1,277,100, and that will be the contribution to our reserve funds that we will talk about next. So that is a pretty high level overview of the changes. And Dusty, you can go to the second slide of this presentation as well.
Betty Ann, this is Ted. I just have a quick question.
Yes, Ted, go ahead.
Yeah, Laurel, thank you. I just wanted to clarify one thing. You'd mentioned that the behavioral health funding had been over budgeted, and so there was some reductions made. I'm just curious, how have our volumes been in regards to behavioral health visits, especially potentially with telehealth? Have we, if we're going to reduce that budget amount, have we had decreased requests for services from patients in behavioral health during the pandemic?
I don't know what the patient request level has been. That's something I could check on with Chris and verify and get back to you. I just know that from the budgeting perspective, we saw less in the first half of the year, so we're planning to accommodate for that. And I know there were some issues with the Medicaid billing and the cycle with that as well, but I can find out specifically what the requests have been and how we're accommodating those if you would like.
Okay, Laurel, that'll be helpful. And just as a quick follow-on, have we increased behavioral health services through telehealth during the pandemic?
I will find that out and get it back to you. Thank you for asking.
Okay.
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Dr. Eppley, I could answer that. So we've actually shifted most of our behavioral health visits over to telehealth, and that would include some of our family home visiting programs like infant and early childhood mental health, as well as the Parents as Teachers program. So our team back in March made that transition, and you all may recall Jamie Larson did a presentation on some of the technology she's using for the infant and early childhood mental health program, where they're using games and interactive tools to engage families. So I would say it's pretty much all done through video technology. I don't know if I'd exactly call it telehealth, but using the technology we're all using every day, GoToMeeting, WebEx, Zoom, etc.
Madam Chair, this is El.
Yes, El, go ahead.
Russ, I have a question for you then. Because of all that, have we lost customers, especially as parents, as teachers?
Madam Chair?
Yes, Russ, go ahead.
Yeah, Commissioner Hasbrook, we've actually done pretty well maintaining what we call like a caseload. So each Parents as Teachers home visitor would have 20 families assigned to them for visits throughout a month period of time. And I would say we really haven't, people drop off the program, but then we recruit new families onto the program. A lot of them will get referrals through like our WIC program or through like Dr. Epperly's family medicine residency. They would refer families to us, and then we get them enrolled. So I wouldn't say there's been, number one, there's not a dramatic decline, and number two, there hasn't been an excessive amount of turnover either. So I think the staff here has done a really good job engaging these families and just using technology versus driving to their home that we were doing prior to March.
The reason why some dropped was because of the technology, or they lacked that technology? I'm just wondering if...
Yeah, I think some families did definitely struggle with it. And, I think we see that right in, even with the situation with schools. Some families have been able to adapt really well to it, and some families not so much. So I think with Parents as Teachers, with that young children, we're working with little kids, preschool usually, a lot of them, yeah, I think it's been a challenge. And we do everything we can to try to work around that, right, and make sure people stay engaged. And I think we've been successful, but yes, there's been turnover probably for sure caused by that.
So I guess what I'm trying to say is the technology is great, it works if you can afford to have it. I mean, that's what we're running into with a lot of folks up there, is that they don't have the computer, so they can't get online and see the agendas or see the meeting minutes or whatever it is, because they just can't afford, or they don't want to be in the technology age, so.
Right.
Something to think about long term.
Sure.
Laurel, go ahead.
Thank you, Madam Chair. Okay, we will move into the reserve fund designations then. Which is the next screen, Dustin, please. Okay, while Dustin is getting that pulled up, we'll just start going over it. Hopefully it'll be popping up quickly here so you can see what I'm talking about. So as I mentioned, when we're talking about the budget revision, we have about 1.2 million that we're looking at putting into our reserve funds. So we'll talk a little bit more about how that breaks out. So this is based on our current financial position, the budget changes we just reviewed, and here is the proposal that we have overall to increase the personnel reserve fund by 36,000. As a reminder, the personnel reserve fund is used for the 27th pay period that occurs every 11 years. An increase of 36,000 in that reserve fund would put us 5/11ths of the way towards having that pay period funded. Normally at this point, we'd be 4/11ths of the way funded. So this provides a little bit extra towards that 27th pay period so that over the next 7 years, we'll be able to put slightly less in year over year or build up a surplus. So it just gets us a little closer to that goal. The next increase that you'll see is to increase the operational reserve fund by $991,100. And this will put us right about at that goal of having a 3-month cash flow reserve, which is the goal of the reserve fund policy. 3-month cash flow is about 2.9 million at our current operating levels. So that gets us just very close to that, just a little bit below. And then the last proposed increase that you'll see is an increase to the capital reserve fund by 250,000. This fund is used for major building renovations or major repairs and maintenance, and then purchasing land or buildings. At this time, we don't have any specific planned projects for that extra 250,000, but we do anticipate that over the next several years, there will be some big things coming up, potentially some major roofing projects at a couple of the facilities. And then that gives us an allowance for other things like the cooling tower that we just had to change the budget for this year, anything big like that that may come up in the near future. So those are the proposed reserve fund designation changes, and I will stand for any questions on that.
Madam Chair, this is Megan.
Yes, Megan, go ahead.
Just for a comment. I appreciate that we all feel good about saving money, but I feel uncomfortable at getting too far ahead on the 27th payroll. If we're keeping up pace, that's great, but I think we all need to keep in mind that these are taxpayer dollars and they shouldn't just get shoved away. So I just hope we can continue to be sensitive to that.
Thank you. Any other comments on that?
Well, hearing none, Laurel, it's a great source of comfort to see that we're getting this operational reserve fund up potentially. We've been working on this, has been a goal for years. So far, we need to talk about a motion to the budget revision and the reserve fund designation. Do I have a motion for approval?
Madam Chair, this is Elt.
Yes, Elt, go ahead.
I'll make a motion that we accept the budget revision proposal and the reserve fund designation proposal.
Okay, thank you, Elt. Do I hear a second?
Madam Chair, this is Ted Epperly. I'll second.
Okay, thank you, Ted. Hearing no further discussion or questions, we'll proceed with a vote by county, starting with Boise County, Valley County,
Commissioner Hasbrook, aye.
Ada County, Dr. Young,
Jane Young, aye.
Dr. Epperly,
Ted Epperly, aye.
Mr. Labrador,
Raul Labrador, aye.
Elmore County.
Representative Blanksma, aye.
Okay, thank you. That motion does pass for that budget revision and reserve fund designation. Thank you, Laurel. Proceeding on, we will have our Western Idaho Community Health Collaboration Report by Alexis Pickering. Alexis, the floor is yours.
Thank you, Madam Chair. It's so great to see you all. I wish I could be there in person. So while Dustin's pulling up my presentation, I'm just going to go ahead and get started. So I know we have a couple new faces. Welcome, Mr. Labrador. Just some background. Dustin, next slide, please. WHC, which is the we lovingly call the collaborative, that's the acronym for it, excuse me. The background for why WHC really became what it is today is because a lot of stakeholders recognize the value in combining and leveraging their shared and individual resources. You know, a lot of our partners in community health are doing amazing work, but oftentimes, you know, they're investing 10,000 here or 50,000 there. It's not, you know, in a coordinated and aligned way. And so WHC allows us to truly leverage, reduce duplication, save costs, and then have a greater impact. And COVID has only magnified this belief, as well as a lot of our health issues are intersectional. So they're complicated. We can't solve them by just sitting in our public health silo and bubble. We have to think regionally about these challenges. We have to be able to include other non-traditional partners in this work to actually be effective. And also, WHC is an amazing opportunity because we can test and scale best practices and initiatives and projects that might be picking up steam elsewhere outside of Idaho. And we can bring it to Idaho and make it more applicable to our communities and see if there's any lessons learned, and then share it across our region and then statewide. Next slide, please. So just an update, it's been a while since I've seen all of you. I wanted to just share, you know, just as a recap, you know, we approached the legislature in 2019 with 4 of our private funders. And thanks to, in large parts, Representative Blanksma, we were able to secure that funding. And then we went back in 2020 and received a smaller amount and we also had more private funding to support this work. We were really busy, you know, setting the stage for this collaboration, understanding our metrics and strategic plan. And then we've already started partnering with communities, which I'll get into later today. So we've got a lot at stake and that we're working on this year, and I'm really excited to just share those updates with you. Next slide. So just since we have a new face, just wanted to highlight what is WHC, the nuts and bolts of it. So we're really based on the collective impact model. It's a multi-sector public-private partnership. And I'm really proud and honored to say I'm the only and first joint employee of 2 public health districts. And we've got 23 diverse members representing public health, healthcare, and social services. And we're really setting the table and all there to address the social influencers or determinants of health and to save costs. Next slide. So this is the 10-county boundary. So the green is obviously central and the orange is southwest. It's almost half the state's population. And you can obviously see, you know, every community has a very different culture, different health challenges, but there are a lot of lessons that can be applied and learned and scaled up across this region. Next slide. These are our funding council partners. So they're the ones that have invested in this infrastructure and have the vision to make this possible. Next slide. And just due to the fact that WHC is the first of its kind in Idaho, and it's really cutting edge across the country, we've been really lucky to have funding to participate in mentorships across the country and to be able to share, you know, our model and what we're doing and also learn from others. So one of those mentorships was with how to share data across sectors. Another one was with Georgia Health Policy Center on learning how to do a wellness fund. And then we also received funding from the Federal Reserve Bank of San Francisco, and they put on a training with Build Healthy Places, which is a national organization that aligns the community development sector with organizations like ours. Next slide. And then I'm really excited to share that we're diving into some really impactful and meaningful projects. WHC really is about working with communities at the ground level. And so we went through criteria, and Elmore and Gem counties rose to the top to partner with first and foremost. So I'll talk a little bit more about Elmore in the next slide, but those are the two counties that we're specifically working with. And then we're also engaging with research on how to do a collaborative regional community health needs assessment. So for those of you that are not familiar, the health systems have to complete a CHNA every 3 years. A lot of our partners, including the health districts, we participate in that oftentimes. A lot of our communities are, because everyone does their own, they're oftentimes asked year after year to complete this. And there's a lot of community burnout. We're not able to have the richness that we'd like to see happen. CHNAs are really expensive. So we partnered with Boise State and had a grad student complete her capstone on researching how we could do this. What are some other lessons from across the country? And so we're using that research to have those conversations with our partners within the WHC region, which is really exciting. We're also partnering with the Idaho Community Health Worker Association. It's a new association, and we're providing our experts on WHC to support their deliverables so they can achieve their results faster. Next slide. And then this is the big announcement. Laurel alluded to this in her budget report that I really wanted to share with you all. WHC, in partnership with the Elmore County Health Coalition, we were awarded the first ever Get Healthy Idaho grant. The Get Healthy Idaho program is a new program with the Idaho Department of Health and Welfare. And, historically, IDHW does a lot of, grants and programs that are very specific to like diabetes and heart disease and stroke prevention. But there's not a lot of opportunity to move further upstream and to have a more place-based approach to solving these challenges. So the Get Healthy Idaho grant is the first of its kind. It's a multi-year grant opportunity. And this first 9 months, we received $155,000, and we're really busy these first 9 months. We've convened a community team. We'll be launching a qualitative assessment next month. So Betty Ann and Representative Blanksma, I'd love to just share that link with you if you want to participate or share that within your networks. We'll be presenting the results in the summer and then getting to work. And then those next 2 to 4 years, that funding will be primarily just going to that action plan. So what's unique about how WHC is leveraged for this opportunity is we'll be, obviously this grant is an amazing opportunity. But naturally, with any type of federal funding, there's going to be some, gaps potentially. There's going to be limited technical assistance. So WHC can fill in those gaps, take it to the next level, and we can see even more investments in alignment in Elmore County so we can get better health outcomes sooner. We'll also be taking lessons learned from this grant opportunity to Gem County and our surrounding counties. Really just demonstrating how these community coalitions and a regional collaborative can work together to achieve these same goals. And as I'm sure, Betty Ann and Representative Blanksma can speak to, a lot of these, health needs assessments that happen in our rural communities, they oftentimes say the same thing year after year. But like obesity is high, tobacco rates, what have you. But if you talk to folks on the ground in Elmore County, they say behavioral health is their big challenge. And so we're really excited to be able to use these funds to do a qualitative assessment and really capture the story of why we're having such hard times getting into better health and why is the suicide rate so high. So hopefully we can capture some stories and be able to leverage that into hopefully more sustainable change. So we've got some key intended audiences that we're targeting, really trying to work with those that are most vulnerable and heaviest hit, especially with COVID. But I'm really, really excited about this opportunity. Next slide. So WHC is also just doing broader policy systems and environmental work. As Dr. Epley can attest to, value-based purchasing and payment models, we have to have good community health in order to also get those cost containments and savings on the back end within the healthcare system. So this is, our lane within this system of partners, I would say, is definitely advocating for whatever system that Medicaid and health and welfare and our systems build, that they don't forget, let's address the social determinants, those key drivers that are resulting folks to having to go into the clinic in the first place. So we've been able to do that. We also, very lucky to be on the Healthcare Transformation Council of Idaho, to be engaged in those conversations. And then we're continuing to talk about shared data needs and collection. Next slide. So looking ahead, we're going to be completing the Get Healthy Idaho grant. I'm sure I'll have if you want me back, I'll be happy to share those results with you and do a deeper dive. Just continuing to collaborate, and we're going to be developing a wellness fund. And next slide. And then that's our website, and I'm happy to take any questions. Thank you.
Thank you, Alexis. Excited to hear about Elmore County and the projects there, so let me know what I can help you with. Any questions or discussion for Alexis?
Madam Chair, this is El.
Yes, El, go ahead.
Go ahead, Ted. Alexis, just a quick question on the behavioral health. Are you guys finding out that most of that is from substance abuse, or is it other issues?
That's what we're really hoping that this qualitative assessment can tease out. Is it poverty? Is it lack of a strength in the family household? Like, what are some of those other drivers? So hopefully I'll have some more information for you.
Okay, thank you.
Yes, Alexis, Ted Epperle here. I was going to ask a similar question around the behavioral health aspects. At the root of all poor health, there's usually some connection with behavioral health. So I'm very happy to see that that's front and center in strategy. When you talk about the intended audience, older adults, working poor, Hispanic community, veterans, that's pretty diverse. What is going to be your approach to each of those groups? Is it going to be through community health workers? How are you going to reach out to those populations?
That's a great question, Dr. Epperle. And so I think so to answer your question, Elmore County has the highest percentage of veterans in the state. We have some great representation of all of those populations, except for the Hispanic communities on the Elmore County Health Coalition. So we just presented to them and said, hey, these are the target populations that we're looking to include on this assessment. And so they're helping us identify those key players. They have those connections. So that's, us coming to them saying, you help us figure out who needs to be part of this. And we've also hired a bilingual consultant who will be also coming up with who are the Hispanic leaders in the community. That's Mountain Home, Glens Ferry, Hammond area, as well as Pine and Featherville. And she'll be conducting those in Spanish with Spanish speakers, and hopefully start building that bridge, because there's a big gap between those two communities, the white and Hispanic population. So we're hiring somebody of the community to conduct those interviews, and we'll have an online assessment as well, and that'll be both in English and Spanish.
Thank you.
Alexis, thank you.
Alexis, this is Betty Ann. Is the VA helpful with the behavioral of the veterans?
So Betty and I haven't worked with the VA a ton. I've only worked with the Veterans Affairs gal Tracy with the Elmore County with Commissioner Corbis. I've worked with Tracy, and I've worked with a few folks with the VFW, but I don't know if you're thinking of more of like the broader VA.
Yes, the broader VA is what I would be thinking.
Okay, no, I haven't worked with them.
That might be something we need to investigate.
Be happy to.
Thank you.
Madam Chair, this is El.
Yes, El, go ahead.
One more quick question, Alexis. When I was on the mental health board a few years back, there was a program coming out that dealt with the inmates that were coming out of local and state jails that kind of got them some pre-release, some mental health issues, setting them up with a place to live, maybe a part-time job, a substance abuse counselor, those kind of things. Do you know, is that program still going on? Is that part of this overall community health that you're talking about?
You know, I haven't been on the board for a little bit too, so I think I'm a little out of touch as well. So I'm going to check back in with the board and see if that program is still running and if it also includes Elmore County, because I think that would be a really good strategy if that aligns with the results.
Well, I think it would be good to keep that in the back of your mind as another potential area where we could improve society as a whole.
Love it.
Thank you.
Any further questions or discussions for Alexis? Well, Alexis, hearing none.
Betty Ann,
yes.
Ted Epperly, I'm sorry. I would like to just ask us to consider Alexis coming back with the data and the results periodically. This is a first of its kind in the state, as Alexis is saying. This is a partnership across health districts for the good of all the citizens in the county. This is incredibly good work, and I'd love to just hear periodic updates on how we're doing. What have you learned? What are the next steps? How do we take it to the next level? All of that would be really, really useful. Thanks, Alexis.
Okay, thank you, Ted. Thank you for your report, Alexis, and we will look forward to hearing from you in our future meetings. Proceeding on with, yes. Who's speaking, please?
I just wanted to say thanks, Madam Chair.
Oh, okay, thank you. All right. Proceeding on with our agenda, we're going to have an update on our Executive Council by Commissioner Hasbrook. El, go ahead.
It's been kind of an interesting 2 or 3 weeks. I guess I don't know where to start. As you guys know, the Executive Council hired Mike Kane as our lobbyist, and he's been doing an awesome job of keeping us up to date on kind of what's coming down in the legislature. The first bill, and I'm sorry I don't remember the name, I think it was House Bill 51, but I'm not sure, was a bill that basically made any kind of mandates that came out of the health districts had to be approved by the county commissioners in their county. And I, along with Bill Lakey and Mike and somebody else was there, we helped Senator Vick kind of go through that bill and write it. We got support from Auto Association of Counties, and I'm not sure where it is in the process right now, but I think that's probably coming down the road. As a county commissioner, I don't have an issue with that. I think that would resolve a lot of the conflicts that we had this last year with folks that, you know, unelected officials are making these decisions, and this will put it squarely in elected officials' hands. So I think that was a good bill. The next item that's kind of concerning to me right now, we just found out about it about 3 or 4 days ago from Mike, is there's a bill, there's some discussion, I should say, about the state pulling all their funding for health districts. And there's a lot of questions that would be involved in something like that. I think it's something that the state's certainly looking at. If I remember right, I think the state funding for health districts is around $10 million. And in our case, I just figured out this morning, it's about $2.5 million for District 4. So how would we replace those funds? Well, one of the ideas was for the legislation being written that would do away with the indigent issue with the counties. In other words, the counties wouldn't deal with indigent issues anymore. Those would go directly to the state, but we would still be able to levy for those dollars, and we could use those dollars to replace the state funding. There's a lot of questions to ask, such as, okay, then who handles cremations, indigent burials, indigent rent, indigent power bills? Do those go to the state? How that process is going to work? And then in some counties, I don't think they raise enough in indigent to make up that difference, depending on which district you're in. The other issue is a lot of our contracts that we have are with like the Department of Environmental Quality and State Department of Health and Welfare, like the septic program and the sewer permits. Would we still have to do those? And could we set our own fees? And how does all that process work when we don't really have the rule of law behind us? And so SEP at IAC has been doing some work on rewriting that bill that would basically say the counties can opt out of that process, where the state or DEQ would take over the septic permits and some of the inspections that, of course, then we wouldn't get paid for. So right now, I guess what I'm saying is just kind of watch what's coming down the pike. I don't know where it's going to go. Nobody really does, but we're all watching it pretty close. I think they're going to have a hearing on this second bill here sometime next week, and I'm hoping I can make it down for some of those hearings, but that's really about all I have. Oh, well, you know how we always have an Idaho Association of Board meetings in June. I think that's all going to be on Zoom this year. There won't be a conference or a meeting place, a convention, so to speak, because of the coronavirus. A few of us on the board felt like we were willing to meet back together again in person, but we took it to a vote and everybody felt like they still wanted to keep the Zoom option open for IAB. So other than that, I think that's about all I have. If you have questions, well, I'll try and answer them, but I don't know everything.
Hey, thank you, Elt. Well, that's a lot to consider. Floor is open for questions for Elt.
And Madam Chair, this is Elt. Megan, if you can add anything to this or any updates, I would certainly accept your help.
Honestly, I dropped off the call, so I don't know that, and I just got back on. I don't know that I feel totally comfortable making comments.
Okay.
I have a question. This is Raul.
Yes,
actually,
Raul,
Megan,
go ahead.
Thank you, Madam Chair. Megan, Eltis just talked about the state is looking to pull funding for the health districts, and I haven't heard anything like that at the legislature. Are you familiar with that issue? I do know about the VIC bill. You know, the number one issue that he talked about was the bill that's from Steve Vick, but I hadn't heard about the other one. Do you know anything about that?
Okay, yes, and apologies. I keep getting kicked on and off and interrupted.
That's all right.
Yes, I do know about that. That's a proposal that's coming out of the governor's office to eliminate the funding for the health districts as a trade-off for Medicaid expansion for the counties. And that was a proposal that was brought last year as well. I think Representative Wood, Chairman Wood, was involved with that. That is something that I have walked away from, but that's the history of it as far as I know. Does that help answer the question?
Yes, it does. And follow-up, Madam Chair?
Yes, go ahead.
Megan, is there appetite for that? It was just new to me, so I was just wondering, is there appetite for that in the legislature?
Madam Chair,
yes, go ahead.
I don't really know at this point. I mean, it's not not printed yet.
Okay.
I don't know a good answer to that. It's rough to be in this environment cutting funding when we've got such a influx. I mean, and we just found out that we're going to end up with another, like, I think it was $1 billion in more COVID money. So, I mean, there's this huge influx of dollars, and I don't know where cuts are coming, and I have not officially seen the actual proposal to eliminate state funding from health districts. I have expressed some concerns about it because if you're going to eliminate state funding from health districts, then you better start taking some of those things out of code like for example, the governor in any way gets to determine what employees make if they're going to be county entities. So I think there's a big unraveling to do there, and it's not as easy as just eliminating funding. So that's my position so far.
Okay. Thank you. And Madam Chair, I have a question for ELT.
Yes, go ahead, Raul.
Since I'm new to this, I'm just trying to understand what the Executive Council does and what authority it has. So how did the Executive Council choose to hire a lobbyist, and was there a vote of all the boards, or how does that work?
The Executive Council is basically the 7 trustees. Each district has a trustee. Yeah. I'm the trustee from this district, and each trustee went back to their board and explained the situation and felt like we needed to have somebody inside on the legislature to keep us up to date, because we knew from the public reaction this last year, the mandates, that there was going to be some legislators probably try and hurt us. And so all the trustees got approval from their boards to go ahead and authorize the hiring of Mike Kane as our lobbyist. It was a $5,000 a month contract, and we hired Mike, and Mike has gone in. He was very essential on the bill with Senator Vick, trying to get with those guys together, and for the county commissioners to end up actually having the final say on any mandates that come from the health districts. I think that's a fair bill. He's involved himself with the other issues. Being a lobbyist, he kind of knows what's going on at the State House and what's the word and what people are talking about, and so he kind of keeps us in that loop. None of us, on a personal level, have time to come down and spend that much time at the State House. We have other lives and other jobs to do. So, and I think it was the right thing to do. I know we caught a little hell off the bat for using public funds to hire lobbyists, but we felt like we needed to protect ourselves and have somebody watching out for us. So that's where we are.
All right, thank you.
Ann, this is Ted Epperlin.
Yes, Ted, go ahead.
Yeah, I've got a question in regards to, you termed it House Bill 51. I'm not sure if that's the right number, but in regards to the mandates to going to county commissioners, this is a really complicated topic, obviously, and it really lies at the intersection of multiple things: public health, economy, politics. If in good faith, the public health departments issue a public health order for the good of the community, which is seen as a mandate, and that goes to the county commissioners for action, and the county commissioners opt to overturn a public health order, and we expose the community potentially to what in good faith was the right thing to do from the public health perspective, maybe not from the other 2 intersectional issues of the economy and the politics. Is there a due process for a grievance of that? In other words, is it an absolute that the county commissioners have all authority in regards to then the public's health? How do we resolve a conflict like that?
Madam Chair, this is Elt.
Yes, Elt, go ahead.
When we first started talking about this with Senator Vick, he wanted to set it up, and I think even Megan had some stuff kind of coming forward too, that the county commissioners would be the appeal board for all of the health district decisions. And I came out and said, there's no way I want to deal with someone who's appealing their septic permit or their pool permit that was denied. That should stay with the health districts. That's their function. But a mass mandate or any kind of mandate should be run through the county commissioners, and then if they decide they don't support it, then the folks in that county can say, okay, the next time around we're going to vote for new commissioners. Now in our case, in Valley County's case, we came to the health district, I think it was in August, I'm not sure exactly the date, and we asked for a mandate in Valley County because we had all of those visitors from this area coming up there to play every weekend, and we could see that we're going to get a huge impact from that. And so we used that to our advantage, and I guess you might say we came to the district and asked for that mandate. There was a lot of talk, Ted, and you've heard it and I've heard it the last year over, there's unelected officials making these decisions. And it really wasn't true because those folks were appointed by that county commission. If folks didn't like what they were doing, they should have gone to those commissioners and said, you need to get those people off, we want someone else. And I don't know if people understood that process. I don't think they did. But in the end, it was the county commissioners that decide who serves on that board. So they were held politically responsible for their decisions on who serves on that board. To me, it was kind of a negotiation with Senator Vick and the fact that I didn't want to have people lining up in front of a county commissioner meeting every Monday, in our case, saying, I want to appeal my septic permit, or I want to appeal the decision of the health district. We did not want that, and so we had to give a little, and he gave a little, and we ended up just talking about mandates only. And I don't know how it's going to work. I agree with you that, all we can do and all we've really done is we've kind of advised people that this is the best thing to do. And there were some folks, as you know, that didn't follow us. Some of the bars and some of the other bigger organizations didn't follow what we were doing. And so we kind of had to play a little hardball with those folks, but I think it worked. And as I keep saying, this was new to everybody. Nobody has ever gone through a pandemic before, so this was our only option, and I think it was the right way to go. And I'm sorry, I can't remember the bill number. I don't think it was 50 or 51. I can try and find that and get it to you, though, Ted.
Thanks, Al, for the explanation.
Madam Chair?
Yes, Megan, go ahead.
Yeah, just for a point of clarification, Senator Vick's bill would be a 10-something. It wouldn't be a 2-digit bill, and I don't know what it is. So just clarifying.
Okay, thank you, Megan. Russ, go ahead.
Madam Chair, this is Raul.
Oh, I'm sorry. I thought it was Russ. Go ahead.
That's okay. That's okay. He probably was offended. I was not. So just to clarify on the bill, the way I understand it, it's not that the health districts are going to issue orders. They're going to issue recommendations, and that goes to the county commission. Is that correct? I haven't looked at the language, but is that correct?
Anything that would be considered a mandate. Mm-hmm. In other words, if they decide that they want to declare Cascade Reservoir as, an algae bloom and not to recommend swimming, those kind of things I think would have to go through the county commissioners.
But it wouldn't be the central health district, the district health, the health districts actually ordering anymore. It would be a recommendation. I'm just
absolutely
correct.
That's the way I look at it.
Yeah.
Is that how you feel?
Yeah, I don't. I haven't actually looked at the latest version of it, but that was the idea. I don't know if it's the health district makes a recommendation or the health district issues the order and then it's appealable to the county. That was my understanding, is if this board issued an order for Valley County, residents of Valley County then would come to you and your fellow commissioners asking for that to be reversed.
Right. And then those elected officials are held responsible on the next election.
And I personally think that's a good thing. I think that's the way it should be, and I believe that it's the elected officials who should. If you're going to be dealing with people's rights, it should be an elected official who does that, who can be held responsible for it. But I appreciate the work that you've done on that bill.
Well, and honestly, most of the county commissioners that I know of, not all of them, but most of them, are there to do the job. They're not there to get reelected.
Exactly.
Because we deal with so many hot topics that'll soon swamp you.
Yeah.
And I think it's Senate Bill 1060, Ted, if you need the number. I thought it was 1021, but you're right, it's 1060. And that's all I have, Betty Ann.
Madam Chair?
Yes, Meg, go ahead.
My understanding actually of the VIC bill is that it requires, if I remember, and if it's the same version, and I haven't had a chance to look it up because my phone will hang up if I try to look it up, but my understanding is that it requires a review. So it doesn't change the district's ability to do, for example, orders of isolation, because that comes from a different section of code. That's actually a section of code that flows down through the Director of Health and Welfare. And so the ability to issue order of isolation, and that's the section of code that's been used for the current orders that are in place in Ada County, that ability doesn't change. But from what I understand from Senator Vick's bill, without having it in front of me, it requires those kind of orders to be reviewed by the appropriate county commission within, I believe, a certain set of days. So it's required to review those orders. That's the process that I understand it.
Madam Chair, Russ.
Yes, Russ, go ahead.
Yeah, so Representative Blanksma is correct. I just pulled up some notes on it. So the review will take place within 7 days.
Thank you for that clarification.
Okay, thank you. Any further questions or discussion points for ELT? Well, thank you, ELT. And hearing none, we will proceed with Natalie Bodine, report on our vaccine status and distribution update. So, Natalie, the floor is yours.
Thank you, Madam Chair, and good morning to the board, and thank you for allowing some time for me to provide an update on Central District Health, our current vaccine planning and distribution activities. Next slide, please. So I'd first just like to do a little bit of a review. I did provide some of this information at a previous Board of Health meeting, but wanted to provide a quick review on our current strategy and how vaccine prioritization and distribution happens and how that affects our current strategy and our strategy moving forward. So Central District Health does follow Idaho's vaccine prioritization and distribution timeline. And that timeline is developed through the recommendations of the Governor's Idaho's COVID Vaccine Advisory Committee, or CVAC, that makes recommendations and follows guidance from the Advisory Committee on Immunization Practices from CDC on prioritization and sub-prioritization of certain populations. And then giving that recommendation and that guidance, the governor makes that final decision, and then the Idaho vaccine prioritization and distribution timeline is approved. So that is the timeline that Central District Health has followed and continues to follow, as well as our vaccinating providers. So the number one goal for Central District Health is to partner and support with our healthcare providers in our jurisdiction who have that current capability to receive, store, and administer vaccine. And healthcare providers that wanted to do this needed to sign up and be approved through the Idaho Immunization Program as a COVID vaccine provider. So we are partnering and supporting those approved COVID vaccine providers. Next slide, please. So here's a current look. I just looked at these numbers this morning. These are our current enrolled providers. So these are those providers in our jurisdiction that have applied and been approved by the Idaho Immunization Program as a COVID vaccine provider. We currently have 123 enrolled provider locations that have been approved, and we have 12 provider locations that are sitting in pending status. So one thing with this number is that this can include a provider that maybe has multiple locations across the jurisdiction. So that number is reflected in the 123. So for example, Albertsons Save-On Pharmacies has 20 enrolled provider locations that they're able to receive, store, and administer vaccine just in our jurisdiction. And we have other many providers like Primary Health, St. Luke's Health System, St. Alphonsus Health System, and others that have multiple locations approved as well. So that does provide good capacity across our jurisdiction to provide that vaccine. And I do want to say that we are updating and keeping a list of our current vaccinating providers that receive a current allocation of doses from CDH, and that is listed at cdh.idaho.gov. And that is updated regularly as we are able to bring on more providers and provide and allocate that COVID vaccine to. Next slide, please. So as I spoke earlier, the governor approves and sets Idaho's vaccine distribution timeline. So this is a document that has been developed and can be found on coronavirus.idaho.gov. And this outlines 4 different groups for vaccine distribution. So group 1, of course, we started our vaccinating efforts in the middle of December with group 1, and that still continues today. We are still seeing some groups and subgroups within group 1 that maybe now have changed their mind about getting a vaccine or still seeking to be connected with the provider. So group 1 included healthcare personnel, those frontline healthcare personnel, and long-term care facilities. Group 2, which is the group that we are most active in vaccinating at this time. So there's 3 different subgroups within group 2, and I'll speak to a little bit more detail on the next slide. Next slide, please. Thank you, Dustin. So this is a little bit closer look at Idaho's vaccine distribution timeline and group 2. So per the governor's announcement on January 12th, this group was opened up for eligibility. And there, like I said, there are 3 subgroups within group 2. So group 2.1, which is in that first shaded box between now and January 31st, this group opened up eligibility. So this included our first responders, which included our law enforcement officers and dispatchers, included our pre-K through 12 grade school teachers and staff. And this is other than medical, because our school nurses and other frontline medical personnel within our schools had the opportunity to get vaccinated and were eligible in group 1. So this is our school teachers and staff. This is our daycare staff, and then correctional and detention facility staff. And it shows that between now and January 31st, but of course we are continuing to connect those subgroups with vaccinating providers in our jurisdiction. And then per the governor's announcement as well, on February 1st, group 2.2 opened up for eligibility, and this included those 65 years and older, which is a large group, a very motivated group. So I will walk through a little bit later on what we are doing as more people become eligible and our limited vaccine supply remains the same, on what we're doing to try to connect people to vaccinating providers that are open for eligibility. And then again, at the very end, subgroup 2.3, we do not know when the governor will open up this group eligibility, but again, a very large subgroup for our jurisdiction, which will include food and agriculture workers, the National Guard, if not earlier, manufacturing, public transit, and of course, the U.S. service workers. Next slide, please. So what is our current vaccine distribution plan? Like I had stated earlier, our main focus and goal right now is to partner and support those healthcare providers that have that current capability to receive, store, and administer vaccines and have been approved through the immunization program as a COVID provider. So how does it work as far as vaccine allocation? So Central District Health receives a weekly number of vaccine doses by type. So we are told how many doses of Pfizer we will get for the week and how many doses of Moderna we will get for the week, that we are then able to allocate to our approved vaccine providers across our 4-county jurisdiction. And again, this is currently done on a weekly basis. So we typically get those numbers Wednesday night, early Thursday morning, and then we have an internal allocation work group that takes a look at our dose allocation and current vaccinating providers and sets up a weekly allocation plan that is then sent to the Idaho Immunization Program, who then places the order for vaccine. And those orders for vaccine in Central District Health may be a little bit different than other districts across the state. We do not have any vaccine that is shipped directly to Central District Health that we then redistribute to providers. We really felt that it was important and most efficient to have that vaccine direct shipped from the manufacturer to the healthcare provider so that they can get those shots in arms as quickly as possible. We did not want to have that vaccine make an extra stop at our location, and that has worked very well for us, and we'll continue to do that moving forward. And then, of course, again, just want to state that our vaccinating providers also follow, and we work with them closely to clarify any questions that they may have, but they are also following Idaho's vaccine distribution timeline and vaccinating within our current priority groups that open for eligibility. Next slide. So this is a look at our weekly first dose allocation numbers. So again, we began our vaccination activities the middle of December. So you can see here several different columns. We have a column that shows how many Pfizer doses were made available to our jurisdiction for allocation, how many Moderna doses, and then of course, how many total doses. And then on the far right, what particular priority group are we focused on or working within? And you can see the progression throughout the week as we continue to move through those different priority groups. Also like to point out that there is some variance. If you look kind of from week to week, our numbers bounce around a little bit. So it hasn't always been consistent, which creates some challenges, not only for us, but for our vaccinating providers. So I think we've all done a really good job about staying flexible, working with the doses that we're able to get on a weekly basis. But it has provided some challenges with scheduling when you're not sure and don't have a consistent number that you're working with. There is an asterisk. I just wanted to explain some of the numbers in between week 10 and week 11. So the Pfizer vaccine is a 5-dose vial, what it originally started out as. And one tray of Pfizer had a total of 975 doses. So you can see through here, week 2, we received 1 tray of Pfizer doses, and that 1 tray needs to be direct shipped in its whole. You do not want to break that tray up. But consistently over the weeks, providers were able to get additional doses out of each vial. Consistently, instead of 5 doses per vial, they were getting 6 doses per vial, and sometimes even 7. So just this week, CDC made it official that they were now going to be counting Pfizer vials as a 6-dose vial. So those week 11 numbers, you can see it looks like we had a pretty big jump. But some of that is due to now a Pfizer tray being counted as 1,170 doses as opposed to 975. And then we did also receive an additional tray. We received 4 trays of Pfizer doses for this week. So that does account for that, that spike that you see there. And then as I spoke on an earlier slide, we are currently working through groups 2.1 and 2.2, which is the 65 plus group, which is a very large and motivated sub. And as you can see from the chart here in our weekly dose allocation number, our demand continues to far outweigh our supply. We have a lot of people that are seeking vaccine, and we do not have enough doses to go around. So I just wanted to share, and I don't have a slide for this, a little bit of what Central District Health is doing to assist those in our communities who are currently eligible, including those very large and motivated group of 65 plus that are having some challenges in trying to schedule an appointment and compete against everyone else in those open eligibility groups. So we do have our emergency call center, which is open Monday through Friday from 8:30 to 4:30. We have a number of call center operators that are able to provide assistance, updates, and help answer questions and guide people to providers in our community and to information that is listed on our webpage. So we also provide weekly vaccine information subscriber updates via email, and this currently is a list of about 6,000 people. So again, just another avenue that we're trying to get information out there and support our communities and getting connected. We're also working with our community partners to help message specifically channels that our seniors can use, working specifically with organizations like Meals on Wheels. We're putting a plan in place to reach those homebound individuals who qualify for vaccine and for those that may have a transportation barrier. We also have liaison team members that work with our more rural communities on at least a weekly basis, if not more. And they are also providing updates and information and access regarding vaccine status and availability. We are participating in different community information panels that target different subgroups, including our seniors. For example, our caregiver alliance panel, and then upcoming the Meridian Library vaccine panel that I'll also be presenting on next. And of course, our social media channels. We do know that social media is a huge avenue for communication for everyone in our jurisdiction, and that we do know that many seniors are in fact on social media. So we do message to the general community, and also, asking those that if they know of someone in their community that, or in their family or in their neighborhood that may need some assistance to access information or to help set up an appointment, to please reach out and help. So those are just a few things that we're doing, but wanted to mention that. We have an amazing public information team that if you have any ideas on more that we could be doing around public information assistance, I know that they would be happy to hear. Next slide, please. So I wanted to provide just a quick update on a couple of federal programs with our pharmacies. So the first was the National Pharmacy Partnership Program. So this was a program between the federal government and CVS and Walgreens, and the focus was really on vaccinating long-term care facility staff and residents. So these doses were, the state supplied out of our allocation doses for this partnership program, so that CVS and Walgreens could go in and vaccinate on-site long-term care facilities that had signed up with them. This program is wrapping up, and doses that were not used by the National Pharmacy Partnership Program, either through an overestimation or maybe uptake was not as high as they had thought, those extra doses did come back to the state and have been reallocated out into our jurisdiction. So that was a great thing there. The other pharmacy partnership program that was just activated in Idaho on February 11th is the Federal Retail Partnership Program. So this is a partnership between retail pharmacies and Health and Human Services and CDC. And pharmacies will receive a direct allocation of vaccine from the federal allotment. So this will not come out of our state allotment, which again is a good thing. And this has many partners included. It has Walgreens, CVS, Rite Aid, Walmart, Costco, Albertsons, Save-On Pharmacies, and then the Kroger Company, which is our Fred Meyer pharmacies. So they are just getting this program off the ground. So they have decided in the beginning, as they're increasing capacity, to first activate the program with Walmart and Albertsons Save-On pharmacies in Idaho. So we did receive some extra doses, which started last week. We had one Walmart pharmacy in Mountain Home that is receiving doses through the Retail Pharmacy Partnership Program. And then, of course, a number of locations with Albertsons Save-On pharmacies in the Treasure Valley that are also receiving direct allocation through this Retail Partnership Program. Next slide, please. So one of the last things I'd like to talk about is the vaccine administration transparency data. So this is per the governor's executive order on January 28th. So this is a look at provider level data, which outlines doses distributed and doses administered. So this is data that is managed by the Idaho Department of Health and Welfare and went live to the public on their state website on February 8th. All data that is shown on these visuals is data that is pulled from Idaho's Immunization Reminder Information System, or IRIS. And that data is updated on their website on Mondays, Wednesdays, and Fridays. So take a little bit of a closer look. Next slide, please. Thank you, Dustin. So these are two different visuals that you will find on the vaccine administration transparency data. So you will see a map on the left, again, by health district region. So we are the central region there in blue. Again, so this is data that is coming out of our IRIS system. So vaccinating providers have 72 hours to report in IRIS after a dose has been given. And then you can click on a particular region, and then you will pull up the visual that you will see on your right. And the visual on the right shows specifically our central district health region and has a list of provider names that are currently vaccinating, receiving allocation, and vaccinating on your left. So just wanted to explain a few nuances and maybe some complexities with this data to keep in mind when looking at it, is that this data does include both first and second doses as distributed doses. It does not just include first doses, it also includes second doses. And again, providers have 72 hours to report in IRIS after that dose has been given. So there is a little bit of I wouldn't call it a lag time, but there is some time between a dose given and a dose reported in IRIS. And it's also important to note that with those second doses, they cannot be given until at least 21 days after the first dose. And second dose shipments typically arrive automatically to our vaccinating providers about a week and a half prior to that second dose administration. So you will see that they may have second dose inventory that they are holding because it is not yet ready to provide for that second dose administration. So wanted to point that out as well. And then lastly,
Madam Chair, this is Megan.
Yes, yes, Megan, go ahead.
May I interrupt for a question, please?
Yes.
The IRIS reporting, that continues to be voluntary, right? People aren't just being reported. I have concerns. It's supposed to be a voluntary reporting system, or is it reported blind, so you're not attaching a name to the dose? Can you explain that to me?
Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
Yeah, Representative Blanksma, I don't know the full answer to that. IRIS is a voluntary system, but with COVID vaccinations, I do know that there is a requirement on approved enrolled providers to input that administration data into IRIS.
Okay, Madam Chair, for follow-up.
Yes, go ahead, Megan.
Yeah, thank you. I appreciate that. But if you can find the answer for me to make sure that people who do not want to be reported into IRIS are not being reported into IRIS, I would appreciate it. Or if you'd prefer, I guess I can go to the Department of Health and Welfare, whatever's easier for you.
Madam Chair, this is Natalie. Representative Blanks, I can try to find the answer to that, and I will get back to you with that.
Thank you so much. I appreciate it.
Yep.
Go ahead, Natalie.
Thank you, Madam Chair. So just the last point on this transparency data is that in looking at the numbers and doses administered and doses distributed, this data does not determine vaccine availability. Again, with those second doses may be showing and look like they're sitting there as inventory. But again, they may have already been scheduled for second dose clinic or for potentially some high throughput weekend clinic. So in looking at some of these numbers, sorry, this is really small, but even looking at Central District Health, which we are the second provider up from the bottom, it looks like we are sitting at 55%, that we actually have 100 doses that are sitting in inventory. But we have actually started our second dose administration clinic this week, so that number will change drastically. But we received those second dose inventory about a week and a half ago, so we have obviously been holding that until it was time to administer. Next slide, please. And just to wrap up, just some summary information, of course, wanted to provide some information and some different websites for Central District Health and the State of Idaho vaccine information page. And then, of course, our number for our emergency call center at 208-321-2222. We have a great call center and operators and managers that are on the phone all the time assisting our communities with vaccine questions. So that is the end of my presentation. I will stand for any questions.
Okay, thank you, Natalie. Natalie, this is Betty Ann. I'm just curious as to how the weather situation across the nation is impacting our supply and administration chain. If you could comment on that, please.
Yep, Madam Chair. It definitely is. We have been watching that closely along with our health care providers and receiving regular updates. Idaho immunization program as they receive those from CDC. It is impacting delivery. There are a number of providers whose weekly shipments have not shipped yet. So they, of course, are doing everything they can internally for contingency planning to try to ensure that they don't have to cancel or reschedule appointments. So we have a lot of providers, which is great, that are working together. They're providing vaccine if they have a little extra to help someone else out. So they're all working together to try to ensure that they're still able to hold those clinics, but it is having some impact. And there will probably be some adjusting that will need to happen, but we'll continue to follow that.
Okay, thank you. Questions?
Madam Chair, this is up.
Yes, go ahead.
Natalie, a couple of questions. First of all, because there are so many folks in the 65 and older group that haven't been vaccinated yet, how do you determine whether or not they get their first shot versus someone who's coming in for their second shot? Is there a time frame that they have to have that second shot, or is it just whoever walks in the door?
Yeah, Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
Yeah, so those second dose administrations is kind of an automatic. So the weekly allocation numbers that we provide to our healthcare providers are first dose. So our providers are scheduling those first dose appointments, and then that person should be going back to that same provider 3 to 4 weeks later, depending on the type of vaccine that they received. Moderna, it's at 28 days. Pfizer is at 21 days. So they should be going back to that second provider who has received an automatic shipment of second doses. So if you're getting a first dose, there will automatically be a second dose ready for you with that provider. They will receive that for you.
Madam Chair, follow-up?
Yes, go ahead, El.
So then, Natalie, then those second doses, are they being counted with the first doses, or is that like a whole separate category?
Madam Chair, this is Natalie.
Yes, go ahead.
So as part of our weekly allocation that Public Health District get and Central District get, we are only allocating first dose on a weekly basis. Those second doses are automatically shipped. So we don't order those per se. It's just an automatic that they're shipped to the same provider and the same dose amount 3 to 4 weeks later for administration. But when you're looking at vaccine transparency data, the Idaho Department of Health and Welfare uses from IRIS, those numbers do include first and second dose numbers.
So I'm just wondering if we should separate those out in the IRIS category just for more clarification. And then my last and final question to kind of go along with what Megan was talking about. When people come in to get their first shot, they fill out a card, they put their name on it, and so that someone is keeping track of who's had one and who's going to get two. And but that information is not going into a database with names on it.
Madam Chair, this
sense?
is Natalie.
Yes, Natalie, go ahead.
Yeah, it does. So, and I can speak to how we do it at Central District Health. When we schedule our first dose, we get our card, and then we actually schedule our second dose at that time. So each vaccinating provider, through their scheduling and management systems, are keeping track of those first and second dose appointments for those individuals.
Thank you, Natalie. That's what I needed to know.
Madam Chair, this is Raul.
Yes, Raul, go ahead.
Natalie, first, thank you for the work that you're doing. This is, I can't imagine how stressful this is right now. But I have a couple of questions, and you didn't really address this. But a couple of weeks ago, I actually came to the Central District Health to get a tour with Russ, and I saw the call center. I saw how well everything was going there at the call center. And then a day later, I start seeing all these reports in the media that Idaho is failing, that we're last, that we're getting the gold medal in being the worst state of vaccine distribution. And what really surprised me was when I started hearing people telling the media that we don't have a central place where people can get their information on vaccines. And I had just walked through with Russ through the call center. I thought that's not true. That's actually absolutely not true. So can you please address that a little bit? Because I'm a little bit confused, and I think the media might be a little bit confused. Are we really last in the United States? Are we getting a gold medal for our vaccine for failing in our vaccine distribution, or are we doing a little bit better than that?
Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
Yeah, so we initially, those reports did show Idaho towards the very bottom as far as vaccine distribution and administration. I'm happy to say we are not last. We have been climbing in those ranks significantly, and really believe it was due to reporting. I think our reporting has caught up, and that administration, looking at doses administered, doses delivered, I think our data has been cleaned up there. So we are definitely not last. And thank you for, bringing up our great call center. We have worked hard, really since the beginning of the pandemic. Our call center has been activated and running full time since March. And of course, that has shifted over the last several weeks with a lot of questions around vaccines. So we do have a central point with our website. Our public information team works daily, sometimes hourly, with our call center to make sure that our FAQs are updated and consistent. Sometimes with the many changes that happen with CVAC and at the state level. So we really want to provide the best and most updated information to those out in our jurisdiction. And then those that also may not have access to technology. They don't, they're not able to log on and click on a website. So just ensuring that our call center, we have enough operators in there so that when people call, they can actually talk to a person that can help walk them through some of that information. And then also kind of explain the process as to, not every provider has the same scheduling system. Not every provider has the same link to call and schedule. So we're doing our best to try to help those in our community. So thank you for bringing that up. I think our call center is doing an amazing job.
Well, thank you. A follow-up?
Yes, go ahead.
Is our issue right now with more, do we need more providers, or is our issue really the weekly allocation, or is it both?
Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
Mm-hmm.
It really is vaccine allocation. We need more vaccine. We're ready for it. Like I think on an earlier slide, we have over 120 enrolled vaccinating locations. And right now we are allocating to about 23. We just don't have enough vaccine to go around. And so we have a lot of enrolled providers out there that are ready to go. They're eager to help. They want to do their part and provide community vaccinations, but we need more supply.
Thank you. Another follow-up.
Yes, go ahead, Raul.
Thank you. So when you look at the 4 groups, I read every single comment that came to the board for today's meeting, and there were a lot of concerns about the immunocompromised population. And I'm not exactly sure which one of these groups. So these are people under 65 that are immunocompromised. Which of these groups do they fall under? And is there something we can do? Other states are actually, putting them in a higher category. So can you explain that to me a little bit?
Yeah, Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
Yeah, so those determinations on prioritization and sub-prioritization, even within a specific group, is determined by the governor's COVID-19 vaccine advisory committee. So they meet every other week. In fact, they meet today from 12 to 2. And then given guidance from the different members on that committee, again, I think they look at guidance from CDC's advisory committee on immunization practices, and they make recommendations as to certain subgroups in different categories and where they should fall on the prioritization schedule. And then those recommendations go to the governor, who then either approve it or seek further clarification. So right now, it doesn't look like that particular group, among many others, are really clearly defined on the current schedule. So we are always hoping when CVAC meets that they look further into that, provide some more clarity and some more definition.
Okay. Thank you.
Chair, this is Jane.
Yes, go ahead.
I've just got 3 questions for Natalie, and one is, do we have the providers covering the rural areas as well? Like, are there providers out there? Or
yeah, Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
Yes, absolutely. We are definitely focused and want to make sure that we have vaccinating providers and vaccine that is allocated to those in our rural areas. We have several locations up in Valley counties. We have Cascade Medical, Albertson, Savon, St. Luke's McCall that we have been distributing and allocating to. The same in Elmore County as well. We have, again, Albertsons, St. Luke. One of our FQHCs, Desert Stage Health Center, has been a huge vaccinating provider in Elmore County. And then in Boise County, we have actually worked with Albertsons Savon Pharmacy to provide a mobile clinic. So we worked with Boise County up in Idaho City to have those kind of weekend clinics to take vaccine up and to provide vaccine to some of those. And we are also working with a healthcare provider out of Horseshoe Bend. So absolutely, we are trying to ensure that we have good coverage across our children.
That's incredible. And then I had another question, Madam
Yes,
Chair.
go ahead, Jane.
We're never live.
Of the vaccines that are coming to the state, are the ones that are coming directly to the pharmacies included in our total of the vaccine that's coming to the state? Or is that?
Yeah, Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
I don't believe that the numbers that are federally allocated directly to certain healthcare providers, like through the Retail Pharmacy Partnership Program, are included in our district's vaccine transparency data. I will dig into that a little bit more for you, but I'm not exactly sure where those specific numbers are coming, as they're going directly from the federal allotment to a vaccinating provider.
Thank you. And then one other, have we had any severe reactions reported in the state?
Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
I believe, and I will have to confirm this, but this was several weeks ago, more towards the start of our vaccine. I do believe that Idaho Health and Welfare did put out a press release that they had two kind of severe vaccine reactions, but I have not heard anything of late. And in talking with a lot of our healthcare providers, just the common symptoms that have been reported are clear. So,
and could we keep track of those if they're related to the vaccine or to the administration?
Yeah, so those are reported in the BEARS system, so the Vaccine Adverse Events Registry. So anything that is an adverse reaction is reported in that.
That's to the vaccine or to the administration?
To the vaccine is my understanding.
Okay, thank you.
Madam Chair?
Madam Chair, this is Ted
Yes,
Epperlin.
Megan, go ahead.
Thanks. I had one quick question. It's kind of, I'm at the Capitol building for anyone not aware, and it's kind of been floating around here that maybe, well, it's been said that the governor has indicated that doses should be given on border counties regardless of the stages that we're in. So even though that, you know, regardless of who's eligible, that those eligibility rules change if you're on a border county and in Sun Valley. Is that a thing or is that not a thing? Can you confirm any of that?
Yeah, Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
Yeah, Representative Blank, I have not heard of that specifically.
Thank you. Good to know.
Ted, did you have a comment?
Yes, Betty Ann, thank you. A comment and just two questions. I know that we've taken a lot of time on this topic, but a lot of people are very interested in knowing. I just wanted to make comment that I think that the plan that Central District Health has for vaccine rollout is a really solid one. It's a decentralized plan. They've done an incredibly good job operationally with the plan. When you take a look at the fact that there are 125 vaccine locations. And if you do the math on that, we really have the capacity to give close to 60,000 vaccines a week. But we're currently giving only 7,000 to 9,000 per week. And that really gets to the question that Mr. Labrador was asking about, is it the amount of vaccine or is it the distribution of the vaccine? And it's clearly, we're just not getting enough vaccine. And in fact, not only not getting enough, but what we do get is erratic, Natalie, as you pointed out. And that's why I think we're ranking, the last I saw was 47th out of the 50 states. It's purely right down to the amount of vaccine that we're getting distributed. And if there's any way that we can help Idaho get more, I know that the distribution system, at least in Central District Health District, is really a solid one. I'll just speak to our clinic. We've given over 2,000 vaccines now, and Central District Health has been a marvelous partner in getting that vaccine to us in a timely way in which we've gotten that distributed. That said, a lot of that is outside of our control. We use what we get in Central District Health. We've got a greater capacity to vaccinate, but we just don't have the vaccine. Now my two quick questions. First of all, with the Johnson & Johnson vaccine that the FDA will consider for emergency use authorization at the end of this month, just a week from now, the Johnson & Johnson Janssen vaccine being a single dose vaccine, has this started to emerge on your radar, Natalie, in terms of a third vaccine coming in? Where does Idaho stand with getting our fair allocation of that? Have we talked about the distribution of that vaccine being a single dose shot as opposed to a 2-dose shot? That could be a real game changer as well for getting a lot of people vaccinated. So Natalie, kind of a question to you in terms of the Johnson & Johnson vaccine.
Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
Yeah, thanks, Dr. Epperly. We are starting to hear more and more information about Johnson & Johnson, the single-dose vaccine that can be kept at refrigerator temperatures, so it does not have those stringent cold storage and administration requirements, which is going to be great. I think it's going to be more mobile. We'll be able to provide that vaccine out to more of our vaccinating providers, have that more readily available for certain subgroups or sectors. I think that will work very well in, specifically maybe our correctional and detention facilities where there may be some movement of people that come in and out of that system. We've already had some conversations with different facilities. You know, they are able to provide the first dose, but then the person leaves their agency, and where do they get the second dose? So I think that could open up some good accessibility across our jurisdiction. So, like I said, we haven't heard a lot. It is expected to be approved by the end of the month, and we could be seeing doses in Idaho potentially even the first week of March. So our fingers are crossed that that all happens.
Great. And my second and last question is around vaccine hesitancy. We certainly have a fair number of people that are hesitant to get the vaccine. I'm just curious, are we trying to educationally message or communicate with appropriate speakers, with appropriate messages aimed at targeted audiences that are more hesitant than others around the vaccine hesitancy issue? Because we won't get to herd immunity, which now is felt to be probably as high as 85%, if we don't get some of the vaccine hesitant folks thinking maybe more positively around the vaccine. So I'm just curious, what are we doing collectively to help with our messaging, our communication to the vaccine hesitant folks that live in our state.
Yeah, Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
Yeah, I think we have a number of things that we are doing there. So, of course, providing the most current and updated information on our webpage, working with our providers. It is interesting, again, depending on certain sectors, the different uptake rates that we've seen. I think we've also seen a fair amount of people that were hesitant at first. Maybe they wanted to see, you know, what the vaccine did to their neighbor or to their coworker, and now we are seeing, you know, groups within that group one that are now coming back and wanting to get their vaccine. And I know that there's a second push within our long-term care community as uptake rates with staff there was at about 50%. So I know that we are working with the state and the other districts to see if we could do additional clinics and provide another opportunity for those folks to get vaccinated. And then, of course, we have different liaisons working in our rural communities to be kind of that point of contact and provide that vaccine information, efficacy, safety, to really promote that. And then with some of our access and functional needs populations, again, working with our state independent living council to reach that particular population. And then we have a refugee liaison that is working with us as well. So that we can provide that kind of trusted information out into that community. So several different things going on there.
Thank you.
Madam Chair.
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Yeah, I wanted to just follow up on one of the questions Mr. Labrador had earlier on, just so we're all clear. So what Dr. Epperly described is we're 47th in the country, but that is influenced solely by the amount of vaccine our state gets, which is generally distributed based on population. So being 47th doesn't mean we're doing a poor job managing the vaccine that we get. In fact, early on, you know, there was some federal reporting suggesting that Idaho was doing a poor job managing the vaccine we were receiving, but as Natalie described, there were some issues with data. Every state uses a different data system, and we were using IRIS. So there were some data entry issues that would have suggested we were doing a poor job administering it, but now that that's cleaned up, I just learned yesterday we're number 18th in the country as far as our efficiency in delivering vaccines. So I just wanted to make sure that was clear for the board and for anybody watching.
Thank you.
Thanks, Russ. Any further questions, discussions for Natalie?
Yes, Madam Chair. This is Commissioner Sturm.
Yeah. Well, hi, Ryan. Thank you. Go ahead.
Yeah. Running behind today, I had to go save a fall victim. So I just kind of wanted to speak to what Natalie was saying about the rural areas and Dr. Young, what you were talking about. I got my vaccination. I'm due for the second one here on the 25th, and it was, you know, no reactions the whole day. We sat down there the whole day. The ambulance did, just to make sure, with the Albertsons Clinic, and the Albertsons Clinic people were great. They did a great job. They were taking anybody that, you know, fell in that age group, that if they had extra, they were getting those folks taken care of, and it was a really, really great process. And I'm really impressed and surprised and happy all at the same time about how Boise County was able to go ahead and get as many vaccinations and as many people vaccinated as they did. There is still, as we've mentioned, a lot of folks that are messaging me and requesting that we that we get more because they want to get vaccinated as well, and there's just not enough going around. And so there definitely is room for improvement, I think. I was surprised that there was that many folks that actually wanted to get the vaccine in the older age groups up here. It did surprise me a little bit, but there's a large number of those folks that want it, and they're reaching out to myself and the other county commissioners and other folks to try to get that. And so anything we can do to help you, Natalie, get more vaccine or whatever the case may be, whatever you need, please don't hesitate to ask, and we'll do what we can. If we got to ask folks to help out, we will do what we can do to get as much going as possible, because it's really picking up a pace, and I'm happy to see that. So thank you for all the work you're doing.
Thank you.
Okay, thank you, Ryan. Any further discussion or questions for Natalie? Well, hearing none, Natalie, I want to thank you for that amazing report and the work you've been doing. And in consideration of the progression of our agenda, I am going to call for a 10-minute break at this time, so we will come back into session at 10:35. Thank you.
Sure. Just one thing for everybody to be aware of, this is still going to be live on the YouTube channel, so just for your awareness over the next 10 minutes, depending on what you do.
Okay, it is 10:35. We will come back into session. Dustin, are we on?
Yes.
Oh, okay. Thank you. Okay, folks, proceeding with our agenda, we will now go to Kim Link, who is our Communicable Disease Control Manager. And Kim, you have the floor.
Great. Thank you, Madam Chair, and good morning, everybody. Dustin, can you bring up my slide set, please? So I'm going to be talking about the epidemiology update for COVID-19, so looking at our data and what we're seeing here locally in terms of illness and transmission. So next slide. First thing I want to talk about is an update on where we're looking in terms of variant strains of COVID. This is, of course, something that is on many people's radar, knowing that these variant strains are causing a lot of illness throughout the world right now. So on a national level, we have surveillance that's going on for 3 different strains. For the purposes of just keeping things simple, I'll refer to them as the British strain, the South African strain, and the Brazilian strain. All 3 have been found in the U.S. The British strain is by far the most common. As of this morning, CDC is indicating that 42 states have found that strain within clinical samples, so coming out of patient specimens, so definitely widespread. The South African strain has been detected in 10 states, and the Brazilian strain has been in 2 different states. So it was definitely news this week. We received word from the city of Boise that the British variant was found in Boise City wastewater, and this was coming from the week of specimens that were taken the week of January 25th. We've not yet found this variant in clinical specimens, but I think it's pretty certain at this point that the virus is here. It was found in low levels in the wastewater. So what does that mean for us? Well, it means that this is a virus that does appear to be circulating within our area, but it seems to be kept in check at this point in time. Again, low levels being found, and as far as moving forward, that means that we're in a position of our goals being to manage the amount of this virus that's in our community. These strains, all three of these variant strains, are concerning from the standpoint that they're known to be more infectious. So we see that they're spreading more quickly and more easily between people. The British strain in particular, we're seeing mounting evidence, information coming out from the UK government that this strain is showing to be causing more severe illness as well, so that's definitely concerning. So we're in a position of looking to decrease that transmission within our communities and prevent outbreaks from it. So next slide. As our case numbers have been coming down, and we'll get into the data on that momentarily, we've been in a position of being able to identify common locations of exposure based on case interview. What happens in our communities as COVID numbers are going up, we lose that ability to really look at where a person's most likely exposure was, because people are oftentimes having multiple high-risk exposures during that 14 days before illness. As the numbers come down, we can really zero in on where transmission is happening within our communities. So talking with our investigators, this is the list of places, exposure locations that we're really seeing coming to the top in terms of exposure. So household members, that's definitely not a surprise. That's going to be something that I think we'll see throughout this illness. We know that when the virus does get into a household, preventing spread from person to person is difficult. It's not impossible, but it's definitely difficult. And so as we look at where we have greater opportunities for prevention, the key question that we ask, and that we ask of our investigators as well, is, all right, looking at that household, for the first person that became sick, where was their exposure? How can we look at preventing the virus from getting into the household in the first place? And one of the primary ways that transmission is happening in the broader community is in the workplace. Unfortunately, what we're seeing right now, and this has been going on for a little while at this point, is that we're seeing transmission among coworkers, and that's happening multiple ways. So we do still have situations where masking in the workplace is infrequently done. There are sometimes gaps in when people are around one another, when colleagues are around one another, and masks are being worn. This happens when, say, colleagues are eating lunch together, of course, is one of the common scenarios. One of the things that we're seeing a little bit more right now than we have in the past is that people are going to work while they're infectious, and sometimes while they're exhibiting symptoms as well. There's definitely a concern by people of potentially losing their job if they're out of work. So they are coming in when it would be advised for them to stay home. The next thing that we're seeing is still community transmission going on. So our case numbers have come down, but we are still seeing a lot of times where when we interview a person, there really isn't necessarily a high-risk exposure. They didn't have a friend, they didn't have a family member who was sick with COVID. They, maybe go out and run a couple of errands a few times a week, and somehow in the course of doing that, they picked up COVID. The next one is looking at is travel. We're seeing that people are traveling out of state and traveling out of the area much more than they have been in prior months. Unfortunately, one thing that we're experiencing is that people are getting on airplanes while infectious, and that definitely provides an opportunity for transmission. We're also seeing, again, as people are traveling out of state, sometimes for family gatherings or different things like that, that the transmission is happening at those out-of-state events. So people are picking it up elsewhere and bringing it back here to Idaho. Small gatherings are still definitely of concern for us. The ones that kind of raise to the top there are looking at things like birthday parties, dinners, and those types of gatherings where we have non-household family members or close friends coming together and spending time together. And then the last one that I want to touch on is school-based sports. And this is something that we've been seeing really since late summer, that we see as the different sports are going on, the different seasons, that there is some transmission that's occurring through those sports teams. And this may be through the games that are being played, practices that are going on, but even other types of activities that are associated with the sports team. So it may be team building events or even things like carpooling or traveling to a game or a tournament on a bus. Right now, for us, I know basketball and cheerleading are the sports where we're seeing the highest number of clusters that are coming out, and closely working with schools, closely working with clubs to look at how we can reduce that risk of transmission. Next slide. So jumping over into the data, I want to take a look at our hospital information. So this is the next two slides, or this slide and the next slide, are Ada County residents. And this first slide is looking at non-ICU census. So these are the hospitalizations, non-ICU, Ada County. And what you can see here is that we have that massive peak that happened between October and January. We've come down from that, but we're still not quite back to that pre-surge baseline. So over the past couple of weeks, we've had 20 to 30 Ada County residents on average being hospitalized for COVID. Back prior to the surge, we were down into single digits for that. So I think our numbers have come down a long way. We've seen a lot fewer hospitalizations than we had a couple months ago, but there's still definitely some work to be done to get back to that baseline. Next slide. So again, this is looking at Ada County residents. This is looking at the ICU census. So again, you'll see that we had that peak that occurred in the November-December timeline. Our number of admissions have come back down, and I feel we're back to that pre-surge baseline. So, and looking at any given day, there are the numbers of Ada County residents in ICU are in low single digits, and that's really what we were seeing before our number of cases picked up in the fall. Next slide. So this slide and the next slide are looking specifically at Ada County hospitals. So we're looking at all the patients that are in our local hospitals here in Ada County for COVID. This first slide is the non-ICU census, and you'll see very similar to what we saw for Ada County residents, that we had that peak. Our numbers have come down quite a bit, but we're not back to baseline at this point. We're still looking at 30 to 40 patients being in our hospitals due to COVID at this point in time. Next slide. So again, looking at Ada County hospitals, this is the ICU census, and similar again to what we saw for Ada County residents, the number of ICU admissions right now is back to where we were prior to the surge. So in those mid to low single digits for ICU admissions. Next slide. So I'm going to switch over into our case data, and I have information for all 4 of our counties that we'll go through here. These are our weekly COVID case counts by county, and there is a red line that runs horizontal across the graph to show the benchmark of 100 per 100,000 cases per week. And this is an important indicator. It's one that is nationally recognized as that threshold of transmission where we see that we're in significant community transmission above this line, below it in lower levels of transmission. Additionally, it really is a threshold for us of where we can find that clarity in contact tracing, of being able to detect the disease clusters, and also where our contact tracing work has the most impact on being able to decrease the number of cases in the community and transmission within the community. So you'll see here again, of course, we had that very high peak that happened over our fall and winter months. Our numbers came down. We did have a little bump up in January, but our numbers have been consistently coming down. Ada County is still above that 100 per 100,000 threshold. We are on track, it looks like, to finally drop below that this week. So that'll be the first time since September 20th that we've been below the 100 per 100,000 mark. That data will be finalized here. We've got a couple more days worth to go into investigation, and then on Monday that data will be available to see where we're sitting for this current week's numbers. Next slide. So here is the Boise County graph. Again, we did see during the fall and winter surge that we did go above 100 per 100,000. Boise County has been below that mark since the week of January 24th. So number of cases among Boise County residents right now is landing in single digits, which is a really good place for them to be. Next slide. So Elmore County, again, experienced a surge over the fall and winter. As we look at that 100 per 100,000 mark, Elmore County's been below that since January 17th, sitting in a much better place than where we were. I think as far as looking at this week currently, I think it'll be close to see whether or not we keep, whether or not we stay below 100 per 100,000. There have been some clusters going on in Elmore County, some things that are sports related that are increasing the number of cases that we're seeing. So definitely something that we're investing our time and effort into to understand where transmission is occurring. Next slide. So Valley County, this was, I know the last time I presented in January, Valley County was definitely an area of concern for me, just seeing the really high numbers that were being reported. We saw a really steep drop-off in the number of cases, and that's been continuing, which is great. I know that there have been, folks going up to recreate in Valley County, and hopefully they're taking all the precautions that they need to prevent any potential transmission from occurring. Valley County has been above that 100 per 100,000 marker since October 25th, and it looks like most likely we'll see those numbers drop below that threshold, hopefully this week as well. Next slide. So percent positivity, this is an indicator that really has kind of followed track with our case counts. This past week, or this most recent week where we have data, which is the week of February 7th, we did drop below the 5% mark. So we were at 4.7% positivity across our health district. And the significance of that 5% mark is once we're below that, we can say that the amount of testing that's going on in our community is adequate to fully understand the level of illness that's going on. When we're above 5%, there is a greater potential that we may have pockets of illness that are undetected and transmission that is not being detected in the community as well. So below that 5% marker is where we want to be, and we haven't been there since September 13th. So it's a great place that we are, and I'm hoping that we will continue to see the percent positivity stay at this level. Next slide. So in summary, where we're sitting right now, case-wise, all 4 counties are showing definite improvement in the reported number of cases. As I mentioned, right now where we're sitting, either right about at or just below 100 per 100,000 per week in each of our counties. And again, the significance of that is that the work that we're doing in case investigation and contact tracing allows for us to detect clusters, and it also allows for us to, through our work, really be able to impact community transmission that's going on through the isolation and quarantine process. So we want to aim to stay at or below that 100 per 100,000 mark when at all possible. Our percent positivity, as I mentioned, is for the first time in 5 months, showing that testing is adequate to the amount of illness that's in the community. And again, what we've seen is that testing has stayed reasonably high, but that we've finally seen that illness level come down enough to where our percent positivity dropped below 5%. Our hospitals are continuing, they're definitely in so much better shape than where they were a couple of months ago, coming back to pre-surge levels in terms of the number of COVID patients that they're taking care of. So we have a number of our metrics that are looking really promising for us right now. That finding of the variant virus, though, is something that needs to give us all pause. This is a virus that we know is more infectious. It's a virus that we have mounting evidence to show causes more severe disease. And as we look at this, I know that we've gone through these surges multiple times now, and we've seen that it takes just a matter of weeks for our case counts to move from the range of being in an okay position to being in really dangerous levels. And then we see that it takes months for us to get back to that baseline, that pre-surge level. I know there's an interest in looking at relaxing our orders that are in place right now. I would encourage you as the board, as you're looking at making those decisions and the timing for those decisions, to make those changes in a strategic and stepwise manner and allow for time in between those changes to be able to see the impact on community transmission. And with that, that's the end of my report. I'm happy to take questions.
Well, thank you, Kim. The floor is open for questions for Kim.
Madam Chair, this is Ted Epperly. Just one question, Kim.
Yes, Ted, go ahead.
The B117 variant, the United Kingdom British variant that you discussed, I've seen in the data that it doubles about every 10 days in the community and across the globe, quite frankly. What are we expecting in terms of when it'll be the predominant strain here in Idaho and in our community? I've heard data around that could be as early as in March. Is there anything that you have seen or run across in terms of the whole transition from the D variants we've had and dealt with through the course of this pandemic to the B117 variant being the predominant form by the end of March?
Madam Chair, Dr. Epperly, I think I've seen the same data as you have from this, that we see experts saying that by March, this can potentially be the predominant strain across the United States. I think where we're sitting right now, we have an opportunity for prevention. So we know that this isn't the predominant strain, and anything that we can do to prevent transmission should be working to prevent this strain from becoming more common. So it's more infectious. We know that it takes a lesser amount of the virus to get somebody infected and potentially ill. So we need, in order to prevent that from happening, we need masking to be in place, especially when people are in close quarters. We need people to continue physical distancing, and we need people to continue to avoid large gatherings. And those three things together, really done consistently, are going to be what help to prevent this from becoming the predominant strain or delay this from becoming the predominant strain in this area.
Thank you, Kim.
Further questions or discussions for Kim? Well, hearing none, Kim, thank you for that amazing report, and hopefully it's encouraging to see our numbers where they are now, and hopefully we'll continue that trend, but obviously caution is definitely to be heeded with this variant that we're facing. So thanks again, Kim. And in proceeding with our agenda, we'll go to a discussion and vote regarding potential actions within the district as to the COVID-19 pandemic. And Russ, you are up.
Thank you, Madam Chair. Yeah, before you deliberate the two orders, one for Ada County, which is more comprehensive, and the second order within our district is for Valley County, and it's essentially a mask requirement in public places and schools and so on. I just wanted to add on to what Kim has shared with you. First is the two goals that we've had in public health since the start of the pandemic has been to protect our vulnerable population and to keep our hospitals from being overwhelmed by COVID patients. So just to be clear, it's never been a full-on suppression strategy. We knew that was not an option, but we also recognize we do have a public health responsibility to keep people from getting the infection in so much as we can, who will face the most severe consequences, as well as maintain our health system capacity. So I just wanted to kind of share, again, where things are. So we have had 444 people have died either from COVID or COVID has been a significant contributing factor to their death in our district since the start of the pandemic, which was on March 13th. So we're coming up on a year. 220 of those deaths have occurred for residents of long-term care facilities. And you'll see my point with that. Obviously, they're a vulnerable population. They made up about half of the deaths. And since we started receiving vaccine back in December, they, along with the staff who care for them, were among the first to receive vaccine. So now that we're heading into week number 11, every long-term care facility resident or staff person who wanted to get the vaccine and could get the vaccine have had the opportunity to get both dose 1, dose 2, and then 2 weeks time frame to make sure that they have adequate protection. So that population, the highest risk clearly based on the mortality, has been vaccinated. Not everyone can get the vaccine, but most people can. Healthcare workers, that was part of our strategy too, right, to protect our health systems from getting overwhelmed. And one of the challenges that they've had has been being short-staffed because staff were out due to infections, they were isolated or out due to quarantine. So the vast majority of healthcare workers in our district would have had the opportunity to get both dose number 1, dose number 2, plus the 2 weeks. So with that, besides the declines that you're seeing with what Kim has shared, the number of healthcare workers, we track that as well, who are showing up positive for COVID infections have declined, I would say, dramatically. We haven't seen the levels that we're seeing in healthcare workers since back in June. In our cases, were really low in June. So that's a good thing, right? Our most vulnerable population has been vaccinated. The health systems have had the opportunity to vaccinate their own staff so that they can be fully staffed and take care of both COVID and non-COVID patients. I also get information from the state on basically it's reported daily, gives a hospital status, where are they at, are they, some stresses, significant stresses, and you recall at previous meetings we talked about crisis standards of care, which is sort of that's the end of the line for healthcare systems, and they're having to transfer patients to other health systems, maybe in-state or out-of-state. So right now, the majority of the major health systems, including the rural counties in our health district, are reporting their full care as normal. So again, it's another really good indicator that they're in a position to be able to care for COVID patients should we start to see swing upward with maybe caused by the variants, for example. The one population that I think the board definitely needs to think about in the discussion is the 65-plus-year-olds. So they could not start getting the vaccine until less than 3 weeks ago. So even for the Pfizer vaccine, no 65-plus-year-old would have been able to receive their second dose even if they got it on day one. And I realize there's healthcare workers that might be 67 years old and they would have been able to get it, but I'm talking about the majority of the 81,000 people who live in our health district. They couldn't have received the second dose, and it requires dose 2 plus 2 weeks to have full protection. So that's, again, I think data-wise we're in a really good position, but there's that vulnerable population plus the ones that Mr. Labrador referred to earlier, people who are younger than 65, who are immune compromised, who probably won't have a chance to even get their first dose for several weeks just because of the supply challenges we've been having. So, you know, there's a lot of uncertainties around the variants. I just saw the news release, the South African variant was detected in a resident of Public Health District 3, so our neighbors to the west. And that person, I guess, had traveled to the South Africa area. So, but again, that's how these diseases get transmitted, as we saw right from the start, was you get on an airplane and travel all over the world, and the whole country lights up with infections, or the whole world lights up with infections. So I just wanted to put that out there. I think we're in a good position right now as far as managing the pandemic. That could change, and I think the question before you now is we've issued orders. They've been in place for several months, as you pointed out, Commissioner Hasbrook. I think it was back in August when Valley County came to us and requested we issue orders for Valley County, because I know the commissioners aren't, they don't have the authority to do that. So we put those in place. So from a policy perspective, is it necessary that we have orders in place from right now, considering everything that's been shared with you today, to accomplish the goal of protecting the vulnerable population and keeping the health systems from getting overwhelmed? It is a misdemeanor to violate those orders, although we all know in our district, it's statewide, there's been very few citations issued, but nonetheless, it's an order. Or do you relax the order and rely on public health advisories, which are strong recommendations that come from me, or agency, to the community? This is what we need you to continue to do to keep this disease in check to the best of our ability. So I'll stop there and answer any questions you have before you discuss the two orders. So the purpose of this agenda item is, do you want to keep the Ada County order in place as is with modifications, or lift it? And do you want to keep the Valley County order in place as is, and I'm not sure what modifications you would make, or lift it? And then we'll move on to the next agenda item after you all make that decision.
Madam Chair, this is El.
Yes, El, go ahead.
Russ basically made all the points that I wanted to make, so I'm not going to go back and muddle through them again. But I do want to mention that at the beginning, the whole intent of the orders were to keep the hospitals from getting overwhelmed so that we did not get to critical care. And I think we've done that, and I'm very proud of the fact that we saved it, we did it, and we should all be patting ourselves on the back for the job we did. If you really think about it, the health districts, all we had was mask mandates, washing your hands, and social distancing. No one's ever been through a pandemic before, so we didn't know how to act, but I think our decisions and our mandates that we put through worked great. I know a lot of people felt like their civil liberties were being impinged on, but hopefully you're still alive and you can still protest because of what we did. With that feeling, I've had the discussion with my other two commissioners in Valley County, and we feel like it's time to relax the order and go back to an advisory-only situation. And I don't know about Ada County, how Ada County feels about that, but it seems to me like we've got this pandemic under control. The public's been educated very well on what they should do to protect themselves. And so I'm going to go ahead and make the motion that we remove the order part, the mandate part of this order from both Valley County and Ada County, and we continue to go with the advisory role, and hopefully people will continue on and protect themselves and be smart enough to know what to do when they're in a busy situation with a lot of folks.
Madam Chair, this is Megan. I'll second.
Okay. The motion has been made and seconded. Is there any discussion before I call for a vote?
This is
Madam Chair.
I'd like to discuss, or
Yes,
go ahead.
Go ahead, Rob.
Dr. Eppley, if you want to, okay. I just want to present to the committee some information that I received from our county commissioners. I have a letter from to the Central District Health Board. Thank you for your continued work towards the health of all Idahoans within the district. Based on the evidence we have observed, we, the undersigned officials of the Treasure Valley, respectfully request that you consider rescinding the district-wide COVID-19 mandates and replace them with advisory orders. And it's signed by Rod Beck, Ryan Davidson, the 2 Ada County Commissioners, the 2 new Ada County Commissioners, and then Trevor Chadwick, the Mayor of Star, Jason Pierce, the Mayor of Eagle, and John Evans, the Mayor of Garden City. We also have a letter from Expo Idaho asking for the order to be lifted, and I would support the motion.
Okay, thank you. Any further discussion?
Yeah, Madam Chair, this is Ted Epperle.
Yes, Ted, go ahead.
Yeah, just a couple comments. I think it's really important that we recognize at this moment in time that with the B117 United Kingdom variant, that things could really worsen again for our community. I don't want all of us and or the community to think that somehow because the numbers have decreased and the vaccine is starting to roll out, that this is all now on the wane. There's a couple of factual pieces here that are really important for all of us to keep in mind. First is that this variant, which is doubling pretty much every 10 days across the planet, is more infectious, up to 50% more infectious, and carries with it a more serious disease. Lethality from this is 20% higher. The other thing, the second point I just want to make, because it's really important to keep in perspective, is that, and Kim didn't actually address this, I probably should have made it a point to ask as a question, is that what we're seeing in the United Kingdom with this and across Europe, many European countries, is that the age group that is being most stricken by the United Kingdom variant are children. In the age groups of pretty much 6 through 12 being the maximum, and the second most common age group are those less than 6. Now, the reason this is important for us to consider is that those groups aren't vaccinated, and they won't be vaccinated for a long time. And most of those kids have young parents, and those young parents won't be vaccinated for some period of time. Kim brought up a very important point, and that is that we need to be careful with this variant and with its potential spread. Now, having said that, I certainly resonate with the fact that nobody wants to have orders or mandates if we don't need it. I think that Elt made a really good point. I think the people that have decided to take this seriously have, and I compliment the community for that as well. Face masking, distancing, group size limitation, not going to work sick, that's all really important. I recognize as well that what we're doing here isn't saying that we're taking off masks and we're stopping all of that. We're just making a change from it being an order to an advisory. With that, I totally support an advisory on this because at the end of the day, I think that The community needs to still take this seriously, and people will continue to that want to. We've not policed it anyway. There have not been arrests or misdemeanor fines applied. So I don't think it has to be an order. But what I want and really want to make sure is clear to all of us is that we must continue with face masking, distancing, group size limitation to the best of our ability until we're really down in our counts to a much lower number, usually around 30 per 100,000. That's kind of a magic threshold that we need to drop to in the community. So all said, I'm also in support of decreasing this from an order to an advisory. But for the community not to be misled by what that means, it doesn't mean that we stop doing the public health initiatives that we've all, I think, really been pretty good about in the community, for the most part, at least those who want to be. I would really strongly message to the community that that's still important. And with that, I'll stop. Thank you, Madam Chair.
Thank you, Ted. Any further discussion before we call for a vote? Hearing none, I will call for Boise County. Ryan, are you there? I think Ryan's got called away again. Valley County, Commissioner Hasbrook.
Commissioner Hasbrook, aye.
Ada County, Dr. Young.
Jane Young, aye.
Dr. Epperly.
Ted Epperly, aye.
Mr. Labrador.
Raul Labrador, aye.
Elmore County, Representative Blanksma.
Representative Blanksma, aye.
Okay, thank you, folks. And that motion
Madam
passed.
Chair,
Yes, who's speaking, please?
it's Ryan, and I vote
Oh,
aye.
hi, Ryan. Oh, okay. All right. Thank you, Ryan. Okay. The motion does pass regarding changing the order to an advisory. Russ, I'm going to turn the discussion back to you for the next agenda item.
Thank you, Madam Chair. I am not going to restate what Dr. Epperly just said, but I can't emphasize his comments enough of how important it is to follow the recommendations in the advisory we're going to issue after this meeting, and I'm going to go through specifically what that advisory says and what we're going to ask of our community. So first, I think this will be helpful. We are a unified district. We serve 4 counties, and we've had two different orders, one for Ada, one for Valley County, and then no orders in place for Elmore or Boise County. And we did have a public health advisory for all 4 counties to address topics that weren't covered in those orders. So I think this will be helpful from a clear and consistent message for all 4 of our counties coming from Central District Health. So that's the first point. As was noted, a public health advisory is a set of strong recommendations from the local public health agencies. That's Central District Health for Ada, Boise, Elmore, and Valley counties. It does not replace or supersede orders that are in place or enacted by a city, for example. I know Boise City has an order in place, or what the state might do. The governor issued his stage 3 stay healthy guidelines. Those could transition to an order at some point. And then you also have the federal government for face covering requirements in a situation like for public transportation. So these are strong recommendations, but if you lived in the city of Boise, you would still be expected to follow the orders of the city of Boise and the mayor. This advisory will replace, it's not necessarily updated, it's going to replace the public health advisory we issued on November 17th. So that will go away, and this will be published on our website again as soon as we conclude the meeting. A couple of points I want to make that are included in the advisory is looking at our data. This isn't national data or global data. but I just want to point out how serious this is for the population that has not yet been vaccinated, the 65-plus-year-olds. So when we look at all of the data that we have had collected since March 13th, if you're between the ages of 65 and 79, you have a 1 in 10 chance of being hospitalized if you get the infection. So it's pretty significant. And a 1 in 30 chance of dying either from the illness or with COVID being a significant contributing factor to the person's death. Now, what's really concerning is the 80-year-olds and older, the risk is increased significantly. So if you get COVID and you're 80-plus years old, you have a 1 in 5 chance of being hospitalized due to your illness, and nearly a 1 in 6 chance that you will die due to your illness. So if you are 80 plus and you get COVID, you have a very high chance of dying from that disease. So my point is, for the next several weeks, as we're working on vaccinating the 65-plus-year-olds, the 65-plus-year-olds who haven't been fully vaccinated plus 2 weeks, exercise extreme caution. The top exposures, Kim talked about those with the workplace situation and then the social gatherings. So and we generally don't see really large gatherings right now. I think people have been responsible, not having concerts and major events where the risk of spreading coronavirus would be significant. So with that said, I just want to go through quickly what the advisory focuses on is wear a face covering that completely covers the nose and mouth at all times around anyone who is not a member of your household when practicing physical distancing of at least 6 feet cannot be maintained. And again, orders talked about public places and rules for different scenarios. It doesn't matter where you are. If you're around somebody and you're within 6 feet, you need to wear a face covering. That's private workplaces, going into a shopping facility, it doesn't matter. Face coverings and distancing are the tools we have until we get our population vaccinated. The other the other point I want to make is the social gatherings. Like Kim talked about, once it's in somebody's household, it's far more difficult to keep that virus from spreading. But when households are intermixing for social events, birthday parties, and what have you, then that's where you start seeing a lot more transmission. That's where we're seeing a transmission. That's the bottom line. That's what's causing a lot of the virus levels that we're seeing right now. And then avoid large indoor gatherings of any type with greater than 50 people present. And I want to emphasize that 49 people does not make a gathering safe. The point of using that 50 threshold is if you do have somebody in that group who is infectious, it's just a fewer number of people that will have to be quarantined as a result of that infection, which affects work and family and child care and everything else we have going on. So we use that number of 50 just to keep group sizes manageable should there be an active case among that group. And the emphasis is on indoor gatherings where there's a lot less ventilation, more likely to be transmitted. As Kim pointed out, when engaging in any sporting, community, extracurricular activities, keep as much distance as possible between the participants and wear face coverings when feasible. So if you have wrestlers on the mat, obviously they can't wear face coverings very well, but the coaches and the wrestlers that are sitting around the edge, as well as the fans, they need to wear face coverings and physically distance. And then for the workplaces, implementing practices to ensure that staff can maintain 6 feet. Wear face coverings when you can't. Here at Central District Health Department, anytime we're out of our immediate office spaces, whether you're going to the restroom or going to the break room, you wear a face covering. And so far, we've been really successful at not having any transmission that has been identified as occurring within our offices. And there's some other ideas there for workplaces as well. And then the last critical point that kind of came up a little earlier with vaccine hesitancy. We need our communities to get the vaccine when it's your turn. And that certainly, I think, will help keep the disease in check. We don't know where this is going to go with the variants and how effective the vaccine will be long term, but for right now, get the vaccine when you can. So that will be the advisory. We have a duration of the advisory. It looks similar to what we had on the previous advisory, and if in fact we see our hospital systems heading in the wrong direction, we're going to bring that back to the board for consideration if you had other actions you wanted to take beyond what we'll have issued in the advisory. So with that, I'll stand for any questions, and like I said, we'll issue the advisory following this meeting.
I have a question, Madam Chair.
Yes, go ahead, Roll.
So one of the issues that was brought up in the comments that were submitted is face coverings for children under age of 2 are not required, but over the age of 2 they are required. And somebody even commented that even California doesn't require face coverings for children under 12. Yeah. So why have we picked 2? It seems like young children, I watch families struggle with this, and I know it's only an advisory, but what happens is when you have to enter a store and things like that, people are still going to be following this advisory, and it seems like 2, we should move that to a more appropriate age. It seems like 2 is too young, when even the state of California is not requiring, and I may be incorrect, I'm relying on the comment from a person who just moved here from California, but it just seems like a really young age to require kids that are 3, 4, 5, etc.
Yeah. Madam Chair?
Yes, Russ, go ahead.
So we're following the recommendations of the Centers for Disease Control in that regard. Certainly, we regulate all the child care facilities in our health district, all the licensed child care facilities. So we have a really close relationship with them. And what we hear from them is those kids wear their masks. And yep, they don't wear them, they fall below their nose, or, you know, there's challenges for sure. But the problem is, if we would say you don't need to wear a mask up to age 12 or what maybe some other states have done, is those kids will transmit that virus to other family members and ultimately grandparents and people that are in a vulnerable population. So it's something we consider, but we generally have followed the recommendations of the CDC on that, and so far we haven't had widespread resistance to doing the best they can. Even from the child care providers, they're able to have the kids wear the face coverings most of the time.
Then I do have a question, another question.
Go ahead.
Thank you, Madam Chair. So, you know, and again, sometimes the media misreports things, and I'm just asking for a friend, but you have as part of the advisory, number 1 says, wear a face covering that completely covers both the nose and mouth at all times around anyone who is not a member of your household when physical distancing of at least 6 feet cannot be maintained. So assume you know somebody, I don't know, you may know somebody who's sitting in the mall and next to his wife and physically distanced from people about 10 or 20 feet. They would be following this advisory, correct?
Not wearing a face covering?
Not wearing a face covering.
That's correct.
And when we had an order, they would have been following the order as well, correct?
I believe that is correct, because it was still when, I'm sorry, Madam Chair.
Go ahead, Russ.
I believe, Mr. Labrador, I believe you are correct, and I have the order here in front of me. Person required to wear face covering. That's correct. Yeah. And others are present, and physical distancing of 6 feet cannot be maintained. So if you can maintain the distance of 6 feet previously, with the exception in public schools, we had different provisions. But if you were at the mall, more than 6 feet from others, you would have been following the order when the order was in place before the board's decision today.
Okay, so maybe the media can get their act together and realize that yellow journalism doesn't work very well in Idaho. Then I do have one last question. Just asking for a friend. I do have a question, one last question, Madam Chair.
Yes, go ahead.
So we received a lot of letters about nursing homes and facilities like that. And maybe we need to clarify to the public and to the nursing homes what this advisory does. And specifically, there's many families that are trying to see their sick family members, people that are, you know, one of the letters that we received touched me because it talked about a person who's dying, who's lost all of her memory, and she can't see her family, and the only thing that makes her improve is seeing her family, and they're being told that they can't visit. So can you please explain what this advisory does and vis-a-vis nursing homes and other facilities like that?
Sure. So there, Madam Chair?
Yes, go ahead, Russ.
Yeah, so for the long-term care facilities, the advisory would apply to, like, the employees. When they can't maintain 6-foot distancing, they should have a face covering on. The same with families who are interacting, you know, within the facility. They should be wearing face coverings and hand washing, not going there if they're sick. And there's federal guidelines out there for long-term care facilities that they would need to follow. So Central District Health is not saying you can't have visitors to a long-term care facility. That would not be coming from us, and the advisory would not limit somebody's ability to go visit a family member. Now, if a long-term care facility would choose to do that as a private entity, they could do that, but it's not from Central District Health as far as some type of restriction.
Okay. Thank you.
Sure.
Okay, any further discussion regarding the advisory? Okay, hearing none, Russ, I'm going to proceed with agenda item number 10 about IAB. The floor is yours.
Okay, thank you. Thank you, Madam Chair. So as Commissioner Hasbrook mentioned, there was a discussion among the executive council members to make a determination on Public Health District 5's decision for whether or not to hold the annual Idaho Association of Local Boards of Health meeting in person, a hybrid, or virtual. So these were just recommendations, and I want to thank our board members. I had sent an email out to you just doing a quick poll, and I had shared that with the director of District 5. So my understanding as far as where it landed is that the meeting will be on Thursday, June 17th, but they didn't decide whether it would be morning or afternoon, but they were planning to just do the business meeting. And the business meetings generally not more than half of a day. In fact, last year, Commissioner Hasbrook, you probably remember, it seemed like it was like 2 hours.
Yep, not very long.
So the director did advise the other public health district directors that they were looking at doing a hybrid option, so people could go there if they wanted to meet in person at Twin Falls. I'm not sure what facility they'll have it at, or you could join virtual. But again, considering it would be a business meeting and it's probably going to be fairly short, you would spend about double the time driving as you would sitting in the meeting. So that's something to consider, but I'll give you more information as they pin that down further. The only other thing I had was for the Friday, March 19th meeting, which is our next meeting, I'll be coming to you with a budget ideas. It's not the budget proposal. I'll be asking for things like what we would like to have from the counties as far as their contribution to our budget. And of course, with the legislation that Commissioner Hasbrook mentioned, that could change things up a bit, but hopefully by then we'll have a little bit more clarity. So I'll be coming to you and I'll say, here's what we'd like to do, here's what we'd like to do as far as staff salaries and any changes in the operating budget. And at that point in time, you'll direct me to go back and work with my team to bring a budget back to you for the April board meeting. So this is budget time, basically, and I wanted to just give you a heads up. So if you have any questions leading up to the meeting on the 19th, I'm glad to visit with you about that. And then at that meeting, you'll have an opportunity to weigh in and provide direction for the agency. And after that, we have our April meeting. You'll approve it or make modifications to it, and then at the May meeting, that's when the chairs from each of the 4 county commissions will vote on the budget, and that basically makes it final for the start date of July 1.
And who leads that budget hearing? What, is it Ada County?
Ada County will, Madam Chair?
Yes, Russ.
Sorry.
Go ahead.
I forget when we're all sitting in the same room together. It's easier to. Yeah, I forgot. So, Commissioner Hasbrook, it is Ada County, so we'll have that budget hearing. We can do it here or do it at the courthouse, and you know, that rotates around each year. So this year is Ada County.
Okay.
That's all I have, Madam Chair.
Okay, thank you. Well, that brings us to the conclusion of our agenda for today. So I will ask for a motion for adjournment.
Madam Chair, this is Commissioner Sturm. I motion to adjourn the meeting.
Thank you, Ryan. Is there a second?
Chair, this is Jane.
Okay, thank you, Jane. Motion's been made and seconded. Any further discussion before I call for a vote? Hearing none, I will call for a vote by county. Boise County.
Commissioner Sturm, aye.
Valley County.
Commissioner Hasbrook, aye.
Ada County.
Jane Young, aye.
Raul
Dr.
Labrador,
Epperly?
aye.
Ted Epperly, aye.
Elmore County. Representative Blanksma.
Yeah.
Madam Chair, I believe she dropped off.
I think she had to go to
She's
another
on the
meeting.
floor.
Okay, thank you so much. That motion for adjournment does pass. I want to thank everybody for their participation in the meeting today and the public that listened in. And extra thanks to our phenomenal team and the work they are doing. So our next meeting, as Russ just said, will be the 19th of March at 8:30 in the meeting. So have a good day, folks, and stay safe. Goodbye.
Bye. Thank
Bye.
you.
Take care, everyone.
Thanks.
Stay well, everyone.
Yan, good morning, teachers. Magandang umaga po
Good
sa ating
morning.
lahat. Okay. Good morning, Sir Jello.
Good morning,
Long
Sir
time.
Franco.
Good morning,
Ayun
Sir
no.
Jambi.
Akala ko may video pa rin.
Wala na. Kompleto na naman tayo ngayon. So, sa ating session for today. Bihirang-bihira na kami maging makumpleto no, because of our schedule din. Tsaka yung mga kailangan pa namin gawin every time sa Saturdays namin. Pero today, we'll have a very special jam-packed session for today on technology integration, a complete guide from design to evaluation. Okay, so Sir Jello, ano bang may expect nila for today sa session natin for our teachers?
Marami, Sir. Sabi mo nga, Sir Franco, talagang jump pack nung ating session. Kasi parang we are giving them a complete guide nung mula pala sa design hanggang sa mag-evaluate na sila. And in the use of the technology, which is something that is very important, especially that we are in this particular setup, especially ng mga nag-online. So, napakaraming pwedeng makuha with this particular session.
Correct. Thank you. No, Sir Jambi, what do you think? Ano bang importance ito? Relevant ba tong session na to? Or baka hindi naman to relevant sa mga teacher?
Actually, ang pagtingin ko dito sa session natin na to, para siyang season ender. Yan, parang it's also our way of evaluating yung mga pinagkaabalahan natin for the past year. Yan. So, sabi mo nga dun sa post mo, Sir Franco, finally, naka-invite tayo ng someone na worthy of giving this talk for us. So, yan, excited ako na tayo rin matuto. Tayo rin mag-self-reflect kung dapat pala ganun yung ginawa natin o dapat ito pa yung mga gawin natin sa future. So, yun nga, in true Netflix fashion, parang season ender. At excited ako para sa season 2.
Yan.
Tama, no, Sir Jam. I agree with Sir Jambi, no. Lahat naman, kasi actually, isa sa mga reason bakit na-design tong session na to, Sir Jambi, was that yung ang dami kasing na-caught off guard dun sa shift to distance learning. Parang biglaan na lang lahat, kailangan na lang mag-distance learning at gumamit ng technology, no, sa pagtuturo. So, madami na-confuse, madami hindi, parang yung iba actually nag-go with the flow na lang, no, yung tipong ginagawa nila, pero tama ba talaga yung paggamit natin technology sa instruction. So, yung tama, no, we'll be evaluating din, we'll be sharing our experiences. So, katulad ng lagi in a very kaagapay teacher support fashion, Sir Jambi and Sir Jello, we're inviting our audience, no, to light up our live chat with your sharing. So, i-send natin yung mga experiences natin, mga nadaanan natin, mga hirap natin, mga tanong natin tungkol sa technology integration, because it's rare, no? Itong speaker natin for today is a very busy person kasi nga trainer din siya. So, he actually just also conducts trainings every time, no? So, mahirap kunin yung schedule niya. So, we're very lucky to have him finally, no, in kaagapay. He has been a supporter sa Jambi, no. Yung mga prizes natin before, yung mga what do you call this, mga mats, actually is coming from him, no. Kasi aside from being a trainer, businessman din tong ating speaker for today, no, from Marikina. So mga taga Marikina po, no, siguraduhin po natin na ma-shoutout natin yung mga taga Marikina later. Kasi taga Marikina po ang ating speaker for today, no? Tubong Marikina, no? A native of Marikina. Okay, so teachers, siguro before tayo mag-start again, no? To answer some of the queries already and questions of our audience, para po hindi tayo masyado magtanong mamaya, no? Okay, una-una, this session is a certified session, so you will be receiving a certificate after this session, okay? And we'll be sending that via email in 5 to 7 days. Pero anong requirement ulit? Kailangan po makasagot kayo ng evaluation. Kaya nga po ang topic natin ngayon ay from design to evaluation. Kasi kailangan nyo pong i-evaluate yung session. That's kidding. From design, evaluation po teachers, no? Kaya po teachers, we always remind everyone, ayusin po natin, make sure po natin tama yung spelling ng ating mga pangalan, dun sa name field, make sure din po tama yung ating email address kasi po pag mali yung email address, bumabalik po sa amin ang inyong mga certificates, no. Naka-receive na po ako siguro ng mga more than 1,000 certificates na bumabalik sa amin. So, please make sure na para din po hindi tayo nag-aalala na bakit wala pa tayo natatanggap na certificates from Kaagapay Teacher Support. Okay? So that's again, no, for everyone. And of course, yung mga live audience natin will be on the front seat, no, pagdating dun sa distribution ng certificates kasi kayo po yung unang makakakita ng evaluation link natin for today. Although, we always naman offer a replay. So yung mga, for example, bigla kayo disconnect, nagkaroon kayo ng problem sa connection, expect that this will be uploaded via our YouTube channel, no, and posted in our Facebook page, no. So if in case, no, by the way, teachers, no, if you haven't yet, no, followed us, please do follow our Facebook page at www.facebook.com/Kaagapay Teacher Support for updates po. Lahat po ng events namin, materials, etc. Diyan po namin pinopost. Okay. So, let's begin na siguro before tayo mag-start. I'd like to introduce our speakers for today. Ako na po yung siguro mag-i-introduce, no? Kasi po baka mahiya yung aking co-speakers for today. Okay. So, of course, we also have for today our my co-administrator,
Nandito pala ako.
Mr. Angelo B. Malyari, no? For today, okay? He'll be covering assessments using technology in instruction. Okay, so we'll be seeing some samples, some practices, no, being done, no, personally by Sir Jello, no. So these are not like the theoretical application technology. It's actually a very active users, no. Si Sir Jello po, by the way, isa sa mga technology integration specialist namin sa Xavier, no. So pag may mga consultations kami, isa si Sir Jello sa mga nag-guide sa amin at isa rin siya sa mga nag-put up ng mga programs for Xavier School. Okay, so actually mabigati na yung speaker natin, no? Bigatin pa yung co-speaker ng speaker natin today, no? Okay. And of course, we also have okay, of course, me, no. Siyempre. Part po tayo, no, sa mga trio po. So I will also be sharing today on assessments naman. So using technology in assessments. Okay. And of course, we also have Sir Jambi for today. And very interesting yung sharing ni Sir Jambi, no. Sir Jambi's sharing will actually pave way to our discussion for today, which is ano yung mga challenges, what are the challenges or possible opportunities din siguro na kinakaharap natin in a Philippine context. Okay? Kasi syempre, ayaw natin na yung discussion natin will not actually be applied in our context. So we'll be focusing more towards the end, no? As we end our session for today, we'll be focusing all our discussions, all our ideas in the Philippine context para mas ma-apply ng mga teachers natin. Kasi kahit gaano kaganda yung mga technologies, applications, mga approaches, no, na existing sa ibang bansa, no, hindi yan basta-basta pwedeng ma-apply sa Pilipinas given our context, no. Sa Sir Jambi, Sir Jello, sa ano pa lang, sa number size pa lang ng classes natin, talo na tayo kasi sa ibang bansa ang ratio is 1:20, 1:10, no. Kaya for example, nung nag-discuss ako ng PBL, hirap na hirap ma-foresee ng mga teachers, no. How do we apply this? And ang laki ng mga class size namin. Sabi ng isang teacher, Sir Jamie, Sir Jello, sometimes their classes would go as high as 60. Wow. Dapat bawal na sin, no? If I'm not mistaken, sa ating dapat hanggang 40 lang ang student to teacher
parang
ratio.
Ano lang yun, Sir Franco, parang natsay.
Oh.
Diba? Ganun yung mga
yes, sa UP. Yung mga big classes na hindi mo na napapansin, ang hirap nang ma-monitor niyan. Okay. Yes. Pero again, part yan, isa yan sa mga madidiscuss ni Sir Jambi mamaya, no, as we end our session. At yan yung magiging focal point natin for our discussion towards the end. Okay? And of course, our invited guest for today, no, actually, dapat hindi natin masyadong kailangang i-introduce kasi kilala na rin sa Pilipinas, no. He's been going around as a training specialist, no. So, We have today Mr. Regan S. Austria, okay, an Apple professional learning provider, okay, from Senko Link Technologies. No? So he's been a training specialist. He's been designing training modules for teachers. Recently released 2 articles on technology integration. Sir Jello, I think we have a copy. No, maybe we could share that to our teachers as well. Although the article already I have shared, I think, no, sa Kaagapay Teacher Support Group. But I hope our teachers will be able to read it because it's something that's very, very important, no, when it comes, no, lalo na pagdating sa technology integration. So it's a very good read, no. So let's not prolong, no, and let's all welcome our invited guest for today, our guest speaker for today, Mr. Regan S. Austria.
Good morning.
Hi. Good morning, sir.
Good morning,
Okay.
sir.
Again, sa mga taga Marikina, ito po ay native ng Marikina, so pride ng Marikina to. Okay, and again, Sir Jambi and Sir Jello, I'm very, very proud to say na is nationally linked and nationally recognized to si Sir Regan in terms of scope, no. So talagang wide ang experience, deep yung experience in terms of designing integration of technology in the classroom. So good morning, Sir Regan.
Good morning.